birth attended by skilled health personnel, and many more indicators. Friends, it is a word to mention that early marriage has been declined in all the south zonal states and UTs, with lowest in Lakshadweep, followed by Kerala. And it is good to know that all the southern zones, states, and UTs have already achieved the replacement level of fertility ranging from 1.3 children per woman in Andaman and Nicobar to 1.8 in Kerala. Friends, the reflection of consistent efforts in health sector by Government of India under the visionary leadership of our Honorable Prime Minister Shri Narendra Modi ji and by the state and UT governments can be witnessed in the various health indicators. Today, institutional birth in country have increased substantially from 79% in NFHS 4 to 89% in NFHS 5. In NFHS 5, more than 77 children aged between 12 to 23 months were fully immunized, compared with 62% in NFHS 4. NFHS 5 shows an overall improvement in SDG indicators in all the states and UTs. Friends, it's heartening to know that women are playing key role in household decision making, ranging from 80% in Ladakh to 99% in Nagaland and Mizoram. The findings of the surveys also highlight significant fall in infant and child mortality rates, unmet need for family planning, out-of-pocket expenditure on childbirth in public health facilities, malnutrition among the children. It's a positive step toward the goal of health for all. Friends, from this juncture, under the dynamic leadership of Honorable Prime Minister Modi ji, we are looking at being a superpower. We are looking to steer the world in years to come. And it becomes all the more important not just to identify and accept the structural gaps in health sector of the country, but also to take the steps required to fix the gaps. In recent years, India has made significant advancement in the way healthcare is delivered in the country. Friends, the first and foremost, we must ensure affordable and accessible healthcare facilities for all. Our government has launched Ayushman Bharat Pradhan Mantri Jan Arogya Yojana for providing cashless treatment to the poor, while health and wellness centers are being promoted throughout the country for promoting overall wellness of the citizens. Further, for providing the health facilities for slum areas and achieving the goal of universal health coverage. Technology have been brought under this Ayushman Bharat Digital Mission scheme. Ayushman Bharat Health Infrastructure Mission is also launched to boost citizens' access to the public health infrastructure by building the facilities for primary and the critical care in urban and the rural areas of the country. Friends, it's evident from findings of the NFHS 5 that the health and family welfare scenario in country is moving at the right direction, at the right place. And I hope that we would be able to achieve many of the sustainable development goals targets well before 2030. I'm happy to note that panel discussion on role of Panchayat Raj institutions in health and learning lesson from southern state on SDGs are designed today, which will be very much helpful for the participants, particularly health officials. And I wish all the very best for your further deliberations under this dissemination workshop. And I'm very happy that NFH's team is doing the well for the serving for the country. And I'm very happy. Dhanyavad. Jai Hind.
Thank you so much, ma'am, for such an intellectual and enlightening speech. I'm sure your words have provided a lot of food for thought to all of us. With these words, now I request Shri P. Manoj Kumar, Chief Director, Ministry of Health and Family Welfare, to deliver a formal vote of thanks.
Good morning to all of you. Honorable Minister of State, Dr. Bharati Parveen Madam, Kerala Health Minister, Srimati Veena George, other dignitaries, senior officers from the state government and UT administration, panelists, health experts, colleagues from Ministry of Health and Family Welfare and IIPS. Ma'am, today we are so happy that such an occasion that we have been joined or we are joined by two eminent leaders, Dr. Bharati Paveen, as well as the Kerala Health Minister, Srimati Veena George, for gracing these occasions. Thank you so much, ma'am, because Madam Bharati has been very supportive in all these activities for particularly this type of survey activities. She has been always, by profession, she's a medical doctor. So always she has been telling that, this data is very important and we need to take it very seriously to take forward for further program implementation. On behalf of Ministry of Health and Family Welfare, I would like to thank Madam Bharati Pawar ji, Honorable MOS, for gracing this occasion and inaugurating this workshop and also releasing the workshop. Thank you so much, ma'am. We are hoping this continuous support in future also. And Madam Veena George, when I met in Gujarat during this Chindan Shivir, I spoke to her. She kindly consented to be this program, but unfortunately, she is in Ernakulam. She is joining with us virtually. That shows that she's very keen to have this type of discussion. Thank you so much, ma'am. And Dr. Rajan Kobrakada, I know him since the last 10 years. So he's also very supportive. He and his team has made us this Trivandrum stay very proud despite this Indian president's visit here. We have not been troubled at all. Thank you so much for your kind hospitality, sir. And my team, Srimati Sandhya Krishnamurthy ji and Director IAPS, Dr. James, for their continued support for arranging this program. And this, not the least, like Sri Vijay, Rajiv Sadanandan sir is in the back side. So he is also with us today and he is also attending this workshop throughout the day. And other panelist, Mr. J. Nivas, Dr. J. Nivas from MD from NHM, Andhra Pradesh. We have so many panelists today. I think they'll be joining shortly. I thank everyone for attending this program and enlightening us maybe this day-long workshop. I hope that this workshop will give us some idea how to go ahead for this the program as well as program implementation as well as this other things. So thank you so much for joining for this workshop. We are hoping to have fruitful discussion in the day long. This is only a formal vote of thanks because madam, they have to leave. There are two more speakers. They will speak once they leave. Thank you so much and Jai Hind.
Thank you so much, sir. Now it's our immense pleasure to invite Dr. Rajan N. Khobragade to deliver his special address that will set the right tone in the right context. Dr. Rajan, sir.
Good morning, everybody. In fact, when you have seen the program, you would have seen that there are a lot of speakers and you would have taken a respite of the fact that the program got changed and it is good. Now let us go back to the basics and start our function today. But as our organizers and everybody, in fact, they wanted us to speak. So I'm standing before you to say a few words regarding this whole workshop and how we would like to go ahead. Our Honorable Union Minister for Health, Dr. Bharati Pawar, our President of today's function, Madam Veena George, Honorable Minister for Health and Family Welfare and Women and Child Development, State of Kerala, all distinguished guests on the dais, my colleagues from Health Department and also from Women and Child Development Department, our experts, Rajiv Sadanandan sir, our former Additional Chief Secretary, Health and Family Welfare, Government of Kerala, Dr. Vijay Kumar, Dr. D. Narayana, who are the experts, health economics and also in public health. and many other experts who have gathered today, and also functionaries from Health and Women and Child Development Department from various states and union territories. Welcome to Kerala. It is indeed our pleasure that all of you have joined for one of the very important dissemination workshop, which we always look forward to when Ministry of Health and Family Welfare, Government of India takes this initiative of having Nfhs one after the other, the rounds in the country to understand what actually is happening. If we know the very basics, in fact, medical science always is having a basic principle that we have to do diagnosis, and once we diagnose what actually is happening to the patient, and then we go for the treatment and the management of treatment and continuum of care and support. So whenever we are having a policies, public policies, and also in fact any welfare measure in the development sector, in fact this whole principle we put to practice, because we would like to see that all these welfare activities and the policies of the government, in fact whether we are going in a right direction, for which we have conceptualized those policies and taken forward in a nook and corner of our country. And there is the importance of such kind of a surveys and the studies which we do on a scientific basis, so that we get the insights what actually is happening at the grassroots level. So if we all have to accept that there is a principle which we need to follow to correct ourselves, in fact our individual biases, our systemic biases, in fact always tell us that whatever we are doing is correct, and therefore we keep doing these things till we realize that there are colleagues from the health department and women and child development department, please feel free to understand what all the findings which are in front of us, and are we agreeing to those findings, or we are having a viewpoint related to those findings. In fact, we should discuss. There are experts among us, and those experts will be definitely telling us. At the end of this workshop, in fact, from the point of view of Kerala, what I feel is each one of us should understand, in fact, what is data and how the data analysis helps us to improve our function. We will be very happy because we would like to have that as a innate ability for each and every functionaries right at the sub-center onwards till the top level. So with these few words, I will stop here. Thank you very much for organizing this excellent opportunity. Thanks to Dr. James and Manoj, who is a good friend of mine, who has, requested us, and we readily agreed that we should conduct such a dissemination workshop in Kerala. And naturally also, this is a good time to be in Kerala. You will be now experiencing rains, and there is a respite from the immense hit all over the country. So spend some more time here, go around even after the conference is over. It will also benefit our economy in a little way. Thank you very much.
Thank you so much, sir, for your wonderful and insightful words. We hope to receive your constant support and guidance in future as well. And I'm sure that the findings of Nfhs will continue to provide us to understand the implementation of our policy better. It's now our immense pleasure to have with us Dr. K.S. James, Director and Senior Professor, IAPS, to address the very intellectual gathering. Dr. James has been a guiding force and a pillar of encouragement behind every milestone achieved by IAPS. So now I invite Dr. A. James to give his introductory remark.
Dr. Rajan Kobragide, the Principal Secretary, Government of Kerala. Srimati Sandhya Krishnamurthy, DG Statistics, Ministry of Health and Family Welfare. Mr. Manoj Kumar, Chief Director Statistics of Ministry. Dr. Rajan, DHS of Kerala, and Dr. Nivas, Mission Director, Andhra Pradesh, and distinguished invitees, and my dear friends. Good morning, and let me also welcome you all to this one-day workshop on the dissemination of the Nfhs 5 results for the southern regions. Southern regions definitely, as Dr. Rajan was telling, has very specific kinds of requirements in terms of the indicators, in terms of really plan for the health sector. Because we have already learned that whether it is the population stabilization targets or whether it is the major indicators of maternal and child health, these states have achieved, or it has gone a long way in achieving these targets, as well as in really coming closer to the sustainable development goals, which is set for 2030. But at the same time, we also feel that there are large areas which are of concerns. So that's why actually these kinds of Nfhs survey perhaps provides us an opportunity to really come together and really discuss which are the areas of common concern, which also perhaps provides an opportunity, as Rajan tells us, when we plan for the next survey. As you know, the Nfhs 6 is now planned for the next year, 2023 being the mid-year of the SDG targets, which we kept for from 2015 to 2030. So it is also gives us an opportunity to really learn what are the areas of concerns in these states and what are the questions we perhaps needs to add in the new questions which we will be evolving over a period of next few months. So thank you that way for all joining, because we have intense sessions which has been planned for the day, starting from the discussion within the state, especially in a state like Kerala. It is very, very important to have a discussion on the localization of the indicators and also understanding how local planning can really help in achieving the higher health goals. So I'm sure it is for the other state, it's a learning experience, and that will provide all of us an opportunity to really learn and understand what is really happening in each of the health sector in each of these states, because each of these states have some success stories, perhaps some deficits, and at the same time, there are several success stories which it tells us which can be emulated for other states as well as for the country as a whole. So thank you once again joining us. As all of you know, Nfhs not only provides an opportunity to really look at the state level or at the macro level, it goes deep into the district level analysis because it provides information at the district level. Not only that, Nfhs also releases the data at the micro data to everyone. So it's an immense opportunity to really understand, because perhaps for some states it is not the district or the area that is a problem. Perhaps it's the characteristics of the population that is a problem. So you may have to really concentrate on the segments of the population which are really lagging in many of the indicators. So the data is also been released to the public. So it is available for many state governments, has been asking us to provide the data which has been given to many state governments. So it provides an immense opportunity because it is, as all of you have known, it's a 6 lakh household survey, one of the world's largest survey which is conducted anywhere. So it is, and it is also a survey which is conducted with utmost care, with providing perhaps, one of the, we can say, technology intensive survey, which because even when the survey is being conducted in the remote villages of any states in India, we really able to monitor sitting at Mumbai what is really happening onto the survey, and also giving feedback to each of the investigators in case there are mistakes, in case there are problems in the survey. So, but there are a lot of things to improve. We understand there are a lot of innovations can still take place. So this provides for us also an opportunity to really understand where are the areas there are concerns, where are the areas where we have to also improve in terms of when we move to the next round of the Nfhs. So thank you for all joining, and I look forward to a wonderful day ahead in terms of its deliberation, in terms of its policies and programs to take forward for these states as well as for the nation as a whole. Thank you.
With the valuable words of wisdom of Dr. James, now we come to the end of our inaugural session. The inaugural session was a very fruitful one, and we hope to have more fruitful discussions throughout this day. Now we would like to break for a short tea. Now we would like to take a short tea break, and the tea arrangements have been made outside the cafeteria. Please help yourself. We will reconvene after 15 minutes. Thank you.
Have thousands of samples there. So obviously you can have good reliable estimates of infant mortality rate even.
Thank you so much for such a fruitful discussion. Also, for the next technical session, the discussion will be on the same topic, that is maternal and child health and nutrition. So children are the future of the country, and if you improve the maternal health, it will definitely benefit the health of our children. In order to throw some light on the maternal and child health indicators, we have our next presentation. The presentation will be chaired by Dr. Govind Bansal, Director, Ministry of Health and Family Welfare, and the presentation will be done by Shri S.K. Singh, Professor, IIPS Mumbai. So I request both of them to be present on the dais.
Am I audible? Yeah. So thank you for this session. So before starting the session, I just thought that I'll introduce my speaker first. So we have with us Dr. S.K. Singh. Many of you would know him in the field of survey, those who are dealing with the data and statistics. But those who may not know him, I would just like to say a few words about him. Dr. S.K. Singh is a professor and head Department of Survey Research and Data Analytics at the IIPS Mumbai. He has published around 200 research papers in various national and international journals, which deal with a wide range of issues, including maternal health, child health, and nutrition. Dr. Singh has been contributing to strengthen the ecosystem of the data in the country right from Nfhs 2, and is continued to be a principal investigator for Nfhs 3, 4, and 5, and is also involved in the planning and implementation of Nfhs 6. So we welcome you, sir, for this session. And as decided, I would request you to please limit ourselves for the 20 minutes so that we can have more focus on the discussion part. Thank you.
Thank you, Dr. Bansal. Good afternoon to all of you. Good morning to all of you. Still not yet afternoon. Yeah, I will not be taking your much of time because our colleagues from ministry has shared with you over 100 indicators which has emerged from our Nfhs. Now, I will be picking only 4 or 5 important indicators related to maternal and child health and giving you better insights. But before that, I would definitely like to share with you one of the important issue on which some of the participants raised discussion. I'm going to organize my presentation under these 6 domains, and in each domain I will be taking 3 to 4 minutes, not more than that. First domain is strategies and innovations adopted by Nfhs to ensure validity and reliability of indicators which is produced by Nfhs, different rounds of Nfhs. Definitely, there has been some changes in implementation strategies, even our contents and coverage. That is why it becomes extremely important for all of you. And then I will be looking at some of our flagship programs. I will be picking only 3 flagship programs which has a direct implication on health and well-being of women and children in the country. Similarly, I will be taking some social indicators because we all are aware that social development, education, age at marriage, and recently emerging issue of JAM, on which our country has given adequate emphasis during last 1 decade. How we are progressing on those indicators, because those indicators are directly, indirectly affecting. I will not talk about pathways. Truly speaking, in this kind of dissemination, we are not giving more insights on pathways when we are going to cover 100 or 120 indicators within a day. And then I will be taking maternal health issues, but I will be taking only 3 to 4 issues. I will be taking you slightly beyond changes over time. And I will also talking about key drivers of those changes and what should be our future course of action. Similar situation, I will be talking very briefly about the child health scenario also. This is my overall plan for next 20-25 minutes. So the first indicator, I wouldn't like to say here much about, because right since inaugural session, we have known much. But one thing is important, that Nfhs has a similar tools and protocols producing data which is comparable for 92 countries, which at par with DHS program. That is why all international scholar, international researcher, even Indian policy makers, those who are working initially in planning commission, currently in Niti Aayog, are using NFHS data for that. Why NFHS is NFHS? Next, because of this, we have adopted a state-of-art sampling design. Our director has in the previous session, while responding to some of the questions, has addressed that, partly that issues. But those who are interested, we can participate in a detailed discussion also. How our sampling design is a state-of-art design, producing valid and reliable estimates, especially when our implementation process has a number of innovations to strengthen data quality. Let us go to the next slide, please. Basically, our NFHS right from beginning has primarily based on 4-pillar strategies. That 4-pillar strategies is continuously getting strengthened. IIPS being academic institutions, we are about 10 students at our institute are currently doing PhD in data quality. Not only NFHS data quality, they are also looking at other surveys, other studies, and also coming where are the flaws in data collection, and whatever is our learning from those studies, those surveys, we are implementing in the next round of surveys. You will be happy to know that 3 to 4 newer strategies we have decided and approved by TSC to adopt for implementation of NFHS 6, including complete digitization of mapping and listing, through which we are developing sampling frame. Okay, out of this 4-pillar strategy, I will not emphasize much. Any new questions in NFHS right from beginning, we are going only after testing for cognitive elaboration and potential for retrieval by the respondents. We are adopting standard survey implementation protocols and ensuring through a suitable mechanism that all survey teams, whether they are working in Lakshadweep or they are working in Ladakh, they should follow those stringent protocol right from beginning to end of the survey. That's our strength. That how we are able to do that, friends. 91, 92, when institute started the first round of survey, there were very limited application of artificial intelligence, limited to only some of the developed countries. But now during last 30 years, we have extensive use of artificial intelligence and machine learning techniques, and that is providing us. Next, please. If someone is interested, our one of the colleague raised a question to Manojji that what we are doing. Sir, so far, we have achieved 6 landmarks in survey implementation process. In addition to our training, capacity building, and multi-layer monitoring of data collection process, we adopted nested design when ministry asked IIPS to produce data not only at national and state level, but also district level. Understanding the challenges of district level estimates, we have several sessions and debated in detail what may be potential challenges when we are moving from state level to district level. That was answer of those. For that answer, we have gone for adequate statistical procedures and done a number of exercise how our relative standard error in estimates will be varying if we are going by plan A, plan B, and plan C, and presented before technical advisory committee But we were not sitting idle those 8 months. Those 8 months we decided what should be a strategy. Along with our ministry, along with our technical advisory committee, we discussed and came up with a very good standard operating procedure in a pandemic situation, because NFHS is the only survey worldwide which has been completed despite of pandemic situation after a gap of around 8 months. So the next slide, which is indicative that because of our standard operating procedure, we are able to manage the data quality. Because in any survey, especially any household survey, where there are a large number of component of biological markers, our anthropometric measures are the first which will be badly affected. Look at that. This comparison is not only NFHS 4 and 5. We are comparing from NFHS 2. NFHS 2, NFHS 3, NFHS 4, and NFHS 5 we are dividing into pre-COVID and post-COVID, and adopted 4 different statistical measures. And all measures are coming within the range, permissible statistical range, whether it is skewness, whether it is cortices, or whether it is mean. It is well within the range, which confirm that whatever process protocols and standard operating procedure NFHS adopted was quite up to mark and successful. Come down, next. A sample size for these states, I am not sure, but it is already given in report. I have nothing to add much in that. Come next. Yeah, flagship programs. I am looking at only 3 programs. Clean fuel for cooking, improved sanitation, and ZAM. Because all these 3 programs are going to affect, basically I am taking health insurance coverage, no? Please come down. Yeah, southern states have made a impressive progress in case of clean fuel for cooking. I am not going to pathways, causation, and theoretical background of that, how this indicator is. But look at that. In comparison to country, all the states has performed better in southern states, but there is a problem across the districts. 2 districts in Karnataka, our colleagues can note that, colleagues from Karnataka, lagging behind. There should be some district specific intervention. Come to the next. Here I don't want to take much time. Yeah, if you look at sanitation also almost similar situation. Only 2 districts which are adjacent districts in Karnataka is the problem. Otherwise, here look at Lakshadweep, 100%. It means that in most of these indicators, our southern states are doing better. Please come there. I am showing this because these are the marker of maternal and child health. Health insurance coverage, you know that after health policy 2017, country is experiencing some shift from welfare measure to insurance based support to the people, to provide them from financial hardship and protect them from impoverishment. That is why it becomes important. When we collected this information, our mission Ayushman Bharat was not completely rolled out. That is why it has not been captured. Sorry for that. I would like to express in detail. Kerala is slightly, our colleagues from Kerala, I am sure some of the colleagues are here. We have already made a special dissemination for Kerala, which in the presence of Principal Secretary Kerala, some 24th of November 2021. 24th of, sorry, I am sorry, Karnataka. We have already mentioned, but unfortunately, most of the districts in Karnataka needs to find out why it is low. I don't have any answer of this question. By analyzing the data, we can give some segregation. I will be giving those segregation in next slides, but not for this indicator. Come next. Even social drivers, if you are looking education, age at marriage, please go ahead. Everyone is knowing that southern states are contributing much better. Still, Andhra Pradesh, our colleague from Andhra Pradesh can think over that. Why there is such a gender gap? I am not presenting gender gap here. Even improvement is also not much effective. And gender gap also is not reducing. Still it is. Next, please. Here, this is a real problem. that we have analyzed. Some of the students have also analyzed the data, and we have participated in discussion. There are a number of social, cultural, traditional drivers creating discrimination against women. That is manifested in marriage, abortion, inheritance, and empowerment. That's not good for the country. All of us are knowing that age at marriage, education age at marriage, are the key drivers of maternal and child health situation, whether it is European country, whether it's American country, or poor Asian countries. Everywhere it is important. That is the same true is happening true, whether it's a Kerala or it's Uttar Pradesh. Everywhere. Next, please. If you look at that, these are the, but for that we are not required. Truly speaking, these are the top three, worst three districts and best three districts. But I am pretty sure we have given in the report, all district officials can sit together with their team and find out. Next, please. If we are looking at JAM, our Honorable Prime Minister is highlighting it since last 5 years. He is highlighting on JAM, Jandhan, Aadhaar and mobile. I discussed with Dr. Wasir from Lakshadweep because we don't have answer of that. What is, how insurance coverage has improved so much there in the previous slide, and why Jandhan is going down there. What may be factor? Otherwise, in major states, what we are looking, digital literacy in Andhra Pradesh and Karnataka is not peaking as it is peaking in Tamil Nadu, Kerala. We will have to look at that, what may be reason for that. Please, next. In maternal health issues, I will be taking only 3 to 4 issues and taking you slightly deeper in that. Please. Manoj ji has already shared these slides. If you look at that, there is a huge economic disparity, economic inequality in 4+ ANC. We know that 4+ ANC is extremely important marker for maternal health program in any country, in any state. Here, Kerala and Tamil Nadu, disparity is minimum. But in Andhra Pradesh, Karnataka and Telangana, still we are getting considerable disparity. Not only educational disparity in Andhra Pradesh and Telangana, but also we are getting here. And Karnataka is also added in that, in most of the indicator. Please, come, next. If we are looking at that, these are the red areas, okay? Of course, 2 districts of Kerala are also landing up in that category, sir. We will have to find out which are the 2 districts, but our colleague Manoj ji from ministry has already highlighted one very important point. In case of Kerala, 3 recurrent floods of Kerala for couple of years, and especially at the time of survey, we suspect that might have adversely affected these process indicator, utilization of these services. We suspect, we are not confident about that. That is why while releasing the reports, we have given it as in a caveat. Our colleague from Telangana, please don't feel disheartened. We know that Nfhs 4, you are having only 11 districts. In Nfhs 5, number of districts has gone up to 31 or 32. If you look at and Professor James has highlighted that Nfhs has done sampling at district level. That has effect on compositional change on the population. That is why that requires further analysis. We suspect that. But if you look at next slide, one very important factor is emerging among poor and non-poor. Though economic disparity is there in southern states, but when we are looking at spatial variation, that is not coming significant. What is meaning of this? Clear meaning of that, despite of economic disparity, our program is able to address those services. People are using those services. Some people are. There is no systematic spatial pattern in 4+ ANC. Basically, most of maternal health indicator can be analyzed. Should I stop right now? Then these are some of the indicators which would only showing slides, okay, has no meaning. Next. Similarly here, institutional births, there is no problem. It is going to be 100% almost universal in most of southern states, and most of southern states are contributing significantly in bringing country indicator at the level of SDGs. Come next. Here I will not show a special variation. Fast, you are also taking time. Still, even some of the Kerala, here our comparer is pushing from this side, giving only 5 minutes. Okay. Yeah, here also there is some problem. C-section delivery, Manoj ji has already highlighted that issue, but we have analyzed that in much detail and going to publish very soon. Sir, adjusted effect of public-private sectors, if you see, from NFHS 5 data, NFHS 4 also was similar pattern. Almost 4 times higher in private health facility. Our 22% C-section births in private health facilities are providers driven and avoidable in nature. I am not ignoring, he argued one thing, that even 6.2% C-section are voluntary C-section also, either because of desired less number of children or they want child to born in a specific muhurt so that their future can be. Whatever is the reason, both are operating there. But Name and Same program was started in 2016 on initiative of our ministry, coupled with Women and Child Development Ministry. But Honorable High Court stayed there because we still consider doctor as God in our country. Next. चलो मैप नहीं आ रहा है, मैप आने में दिक्कत कर रहा है. Okay. Yeah, look at C-section situation. Red. You only suggest. We are not right person. We, a statistician, can give you a statistical number, but you are the right person who can say what should we do, how should we proceed. चलो आगे बढ़ते हैं. But if we look by education, our spatial autocorrelation is coming significant, which was not significant in case of my earlier indicator. But here, in case of C-section, education has a definite impact. It means that those who are more educated want less number of children. There, what Manoj ji argued is emerging true from this analysis. Education has a significant autocorrelation, a spatial variability. Chalo aage chalo Manoj. Anemia also, he talked about that. We have analyzed that also in detail. Okay, I am left with 2-3 minutes only. What is happening in our country? Only 45 to 50% of anemia is being addressed by iron supplementation. Remaining half of anemia are either nutritional anemia, sickle cell anemia, anemia due to various kind of other infection like hookworms. That is why our feeling is, it's our feeling only. You are the best judge to what should we do. That Anemia Free India program should encompass all those components. Our maternal health division will be the right to see that questioning whether you are taking venous blood or you are taking this capillary blood, that is not going, in my opinion, not going to make much difference for the country. Because even if you are taking capillary blood, we are getting a trend. If trend is showing high, it means it is high. Some adjustment, some correction factor may be developed. Next. Yeah, look at that. Even in anemia also, there is a huge disparity, including Kerala. Huge economic disparity. And Kerala is the state where we completed, not only Kerala, except Tamil Nadu, remaining all states we completed survey in COVID. No one can blame that disruption in supply chain might have resulted into this. This is a natural situation which is across the country and we cannot blame COVID here. And for your kind information, I have also analyzed the data. On this Poshan Abhiyan. And it is clearly emerging that, food, supplementary food has been disrupted, but COVID services in healthcare for both women and children, that has not been. Villages has been very conscious about that. At village level, that kind of stigma was not prevalent, which was observed at urban level in the country. Stop the slides. I don't want to. Okay, let us move to child health. In case of child health, except Andhra Pradesh, just stop this presentation, let me go and complete within 2 minutes. Okay. In case of child health, we if you look at the exclusive breastfeeding, except Andhra Pradesh, remaining all South Indian states has improvement in breastfeeding on the line of our ethics of ma program. But Andhra Pradesh, there is a slight decline. I don't know why it is. Our colleague from Andhra can think about that, what should be future strategies. In case of malnutrition, Manoj ji has shown those indicators, and it is clear that there is a decline, but the decline is not significant. How any statistician can expect that indicator like stunting, which is outcome of chronic nutritional deficiency, can be addressed within 4 years period? No. I am not showing the slides, but look at the report. All South Indian states, there is a huge variability in stunting by economic wealth of the household. That is why, again, we will have to focus there. Another problem in southern states is emerging in obesity. Overweight among children who are +2 standard deviation. They are also following the lines of young adult men and women, adolescent and young children. It means there is a huge dietary transition in our country that is holding true even in southern states also, and we are already getting increasing burden of non-communicable disease. That is happening. I don't want to go in much detail why it is happening, why those dietary transition is happening. I don't want to go, but one thing is definitely that is contributing in increasing burden of NCDs in our country. Per capita consumption on junk food has increased 5 times in last 10 years in terms of purchasing power, in terms of consumption, in terms of consumption expenditure. That is why this is the hard time where we should also prioritize addressing transition in dietary practices as a strategy to address NCDs in the country. My colleague will be presenting that subsequently. Thank you. Thanks a lot. With this, I hope I am clear.
Thank you very much, sir, for such a lucid presentation. It's not easy to cover these huge topic in within the time span of 20-25 minutes, but sir has tried well to contain as much as we can. But certainly there are few issues which are still pending and which might be boiling in the heads of many people who are sitting here. So I would request if there are any burning question, maybe you would like to ask them. So please, if someone can pass on the mic, please.
Yeah.
I am Dr. Narayana. I once a while dabble with Nfhs data, but I'm not going to draw my conclusions. I wish to, point out that there is a very interesting paper by Professor Arnab Mukherjee, which appeared in the Indian Public Policy Review, November 2021. I hope some of you have seen that. What he did there, compare the performance of Karnataka districts, taking 6 indicators for children: wasting, severe wasting, stunted, weight for age, anemic, and vaccination. The measure for 2019-20 was compared with NFHS 4, and aggregate measure was arrived at performance of districts. And what did he conclude? I quote, districts with a ratio of 50% or more are colored red in this column to identify districts where there is a convergence of failures on multiple dimensions, because he had taken 6 indicators. For example, Chikmagalur and Dakshina Kannada both have a score of 67%, indicating that it is falling behind on 4 of the 6 dimensions. These are wasting, severe wasting, stunting, and weight for age. Thus, this column identifies a geographic focus of where the priority is most needed. Now, this conclusion is really surprising, because what are the, which are these poor performing districts? They are Chikmagalur, Dakshina Kannada, Kodagu, and Shimogga, and Uttara Kannada. All have much better human development indicators. And if you take the percentage of women with body mass index below normal, these are the best performing districts. But, once he takes a different measure, these are the worst performing districts. Now, this is something, do you want your district level estimates be used like this? Now you have no control over that. Once you put that out, now you have a huge problem. I just don't understand why one has arrived at this sort of a result. Thank you.
Thank you, sir. Yeah. Yeah. Basically, we have a detailed discussion with government officials in Karnataka, and they are also planning another district level survey in which IIPS is helping in order to maintain comparability with Nfhs. They themselves are having certain dilemmas, but we are confident about our estimates. In Karnataka, one emerging issue has been found in Nfhs, that now it has been worst state in case of women's empowerment. For paucity of time, because she put me a cheat, I have to deviate from that. Let me show that slide. Can you please open it? While spousal violence in Karnataka is creating a huge problem in the performance of maternal and child health indicator. Population stabilization is one issue, but most of the process indicator without their alcoholism is playing the very worst role. Intergenerational violence is putting second important marker of that. Alcohol consumption. And not only that, even violence against, come down, next, go. But I didn't put, yeah. You will have to go to violence 2 slides to answer search query about Karnataka. How basically people are debating why Karnataka has suddenly changed in this. And I prepared answer for that. And that is resulting into even malnutrition among children and utilization of other maternal and child health services also. अगर नहीं हो तो अभी छोड़ सकते हैं. We can discuss with sir subsequently. Yeah. Okay. Yeah, that's fine. If social media, even Facebook, or also why Karnataka is going in those directions. Yes, sir. Please.
My question will be related to the insurance indicators what you have put. Two questions in this regard. One
Insurance
is
in which
Yes.
state?
Andhra Pradesh.
Andhra Pradesh, sir.
Yeah. See, two questions. One is that whether you are taking into account the local parlance or the local schemes or the names what they, the state has taken up while conducting the survey. And second thing is that when we have a very reliable data in terms of health insurance coverage, and when the data speaks very clearly, for example, in Andhra, we have 85% of the population is covered under health insurance cards. And whereas in the survey we shows about 70.2. So what
It's not 70.2, sir.
Yeah, it is
It's
showing.
80.2.
No, actually in the ready reckoner also it's shown 70.2.
No, yeah, in my presentation, if you look at, can you show the health insurance slides?
Even a health insurance, it is still 85.
Okay.
We have about 1.4 crore.
There is a statistically significant difference between 80 and 85?
Definitely, because
no, it's
5%.
5% at the level of 80 is not a problem or anything. If you look at, then you will have to look for all comparability with HMIS data, your managed system data, health system data, and a random survey from community-based selection of household, all bound to have some differences. You should never expect to match 100%. Some difference should be there, but those differences should not be very profound. Okay?
Yeah, because
that's
when we saw 70.2,
no, it's 80.2. It's 80.2. Don't get disappointed.
But still.
Okay.
And question is, because we have a local scheme called Arogyasri.
Sir, we have included that.
Will be asking.
Have you seen our question?
No, that's what I'm asking.
Questionnaire in his public domain. We have clearly asked whether any member of your household has been covered by any health insurance or health financing scheme. So whenever we are talking health financing scheme, we are taking care of your all state government sponsored programs and services. Sir, yeah, basically, yeah. Sir, yeah, we will change that. If you look at our national report, that we have changed in our national report.
Yeah, so what is saying is correct. You have shown 70.2. It's corrected later. Okay.
I think if there are corrections which needs to be made, we should make it.
That's fine. Yeah, we will make.
This we have seen in some other states also, not as part of this, but when triangulate some other data, what the state claims and what people report are two different things. Just because cards have been issued, there is no reason that people will know how to access services. Now, what the value of NFH is that you are taking it from the client's point of view, so which gives a kind of validity which may not be available when you go by government statistics. So, and we've had problems in dealing with some states who claimed that they had 100% coverage, but when you look at the data, it was only 35%. In fact, if you look at another state which covers 100% coverage here, when I won't name the state, but it is very, very low. So that disparity will always be there when you see it from the government's point of view and from the client's point of view.
Sir, that situation we are facing right from first round of NFHS 92-93. That government MIS data shows something else, and whenever we are doing community-based cross-sectional surveys, the reports are drastically different. That is why it is called third party. It is called a third party evaluation of government program because IIPS is doing it. Of course, ministry is facilitating us. That is why no one should think about that. It's a implicit differences in government statement.
Thank you. So we can take one more question if it is there. If not, then maybe we'll just.
That madam wants to say something. I don't.
Last question.
Madam, it would be better if you tell about states also.
Sir, I am Minsha from Puducherry. Sir, I have a question that I am from NHM department. We are getting only 3 months maternity leave, and we have to give 6 months. How is it possible for us to give 6 month exclusive breastfeeding, sir?
Yeah, you are right. You are right. All our colleagues from Ministry of Health will take a note of that.
Thank you. Thank you for asking this question. So,
it is actually just 6 months as far as women and child guidelines is there. It is for 6 months.
Is not following that.
I don't know why it's not being followed in Puducherry, but as per the guidelines, this is 6 months if I'm not wrong.
As far as the guidelines of Ministry of Women and Child Development, the maternity leave is for a period of 180 days.
Okay.
I think
So,
we are completing our time.
yeah, so maybe just go back. And
state is center ke liye we have this guidelines.
So for the states, if they have amended something into the guidelines issued by the central government, I can't comment on that. So thank you so much for asking questions. So basically, in this session, we had a very good discussion, and also the factors like the gender and the economic inequality within certain states with respect to certain indicators were also highlighted. So this was a good discussion, and we could also had few questions also. And the beauty of the session is that it helps us
Please maintain silence. The
it
session
helps
is
us to
still
discuss on issues which are kind of which leads to an argument sometimes. But basically, we need to be more. Uh, we need to have an approach of more of triangulation because there are certain different data sets. As Sir mentioned and other subject experts have also mentioned that there will always be a chance of certain differences with respect to different data sets. So we need to understand if there is any gross difference, then yes, it's an issue. If not, then definitely it gives a chance to introspect ourselves and to introspect the data sets that we have through different various methods. Thank you so much for listening to us. Thank you.
Thank you. Thanks a lot. Thanks.
Thank you to Dr. Govind and Professor S.K. Singh for a fruitful Yes, speak again.
All are requested to kindly take their seats. Please take their respective seats. We are about to begin the session. The chair is already there on the dais, so please settle down as soon as possible. India is a signatory to resolution adopted on transforming our world, the 2030 Agenda for Sustainable Development at the 70th session of the United Nations General Assembly held on 25th September 2015. To talk in detail more about the Sustainable Development Goals, learning lessons from the southern states, we will now have a panel discussion. To chair the session, we have with us Dr. Rajiv Sadanand, former Additional Chief Secretary, Health, Government of Kerala, presently holding the post of Chief Executive Director, Health System Transformation Platform. Dr. Ratan U. Kelkar, MD, NHM Kerala. Dr. Priya Vasantha Kumari, Special Officer, NHM Tamil Nadu. And last but not the least, Professor K.S. James, Director, IAPS. The floor is all yours, sir.
Thank you. In the morning, we had presentations on how the southern states are doing in many of the parameters. And when you look at the Niti Aayog index on the movement towards SDGs, you'll also find the southern states do reasonably well. So what we are looking at in this session is, and one major problem in reporting for our Kambir talked about how we are a signatory to the SDG conventions. One of the problems in responding to SDG is actually to come up with indicators that we can respond. And Nfhs, the DHS as is known internationally, is one of the sources for the SDGs for many items. So what this session will try to do, starting with the presentation by Professor James, is to look at what are those SDG indicators, not all of them, in fact, all of them aren't too many. What are the key SDG indicators that come out of Nfhs? And not only health, but also the other determinants of health, which is also covered by Nfhs. And then there are lessons to be learned from the data that Professor James presents, and I will request Ratan to. What we'll now have is a chance to put Ratan on the mat, because he asked all of you, what are you doing? So we will ask Ratan what he's doing about what the Kerala situation. Madam Vasantha Kumari was she'll be joining. Okay, so hopefully she'll also come, and then whatever time is left, I will try to make a few remarks. So over to you, Professor James.
Okay, thank you. Thank you, Rajiv. And this is primarily, I will be giving a basic overview of what is really happening on the Sustainable Development Goals and taking indicators from the National Family Health Survey 5. So, as Rajiv has told, I will be taking only a very limited number of indicators, but primarily also looking at the determinants of health, the social determinants of health, and how far actually we, as a southern state, is in what position we are currently, and also looking at the all India situation. Primarily, I want to really see, because we always consider southern state as significantly different from other parts of the country. So we also need to see in this context how far we are different. If we are different, which are the areas where we are different, and then how do we really learn lessons for either learn lessons or we give lessons to other states of the country. So let me first go to, I think this is the context. I don't think that we really need to tell about it, because the health importance of health monitoring for achieving the SDG goals is well known to everyone. And because we ultimately come back to the question whether no one is left behind. If that is the question, that question inherently tells you some equity analysis. So equity analysis means, it can be by the region, it can be by socioeconomic characteristics, or it can be by various other means, whether we really need to do analysis and then see who are the people who are left behind. Although my presentation, I am not really getting into that detailed aspects, but primarily at the end of the day, I think NFHS data needs to be utilized for the purpose of understanding who and what context they are left behind. I think that's the purpose of providing this data at the micro level, at the disaggregated level. So next, please. So, ultimately, we also know in the country, I think there are large number of indicators. Right now, currently, there are around 26 indicators of health indicators comes from the National Family Health Survey. I think the next round of NFHS we are launching and which we are enhancing it, I think it is going to be something around 34 indicators. It means that almost 80% or more than 80% perhaps, the indicators from the health is coming from the National Family Health Survey. That's also the case with many other the goals, because we have also a number of indicators which really feed into the other goals. So altogether, NFHS provides indicators now around 34, which will be enhanced to something around 40 indicators over the period of time. That is what we expect to capture through the National Family Health Survey. Next, please. I think it's also very important to remember that, SDG goals are also closely interlinked. So we cannot really study the health goals without understanding what is really happening into the poverty, or without understanding what is really happening to the nutrition aspect, which is a goal 2, or that matter which is happening on the gender equity. So once we look at SDG goals for the health, we also need to really keenly analyze what is really happening to the first goal and the second goal, especially the poverty and the nutrition, and also the women's health, and perhaps the indicators like the environmental indicators, the pollutions, and all those things becomes much more important, particularly when we speak about states of southern states where we are really moving to the advanced epidemiological transition as well. So next, please. So let's forget about this. So altogether, what is actually we really see in India, if you really look at overall, we see that India has made very remarkable progress. I think today morning there has been several presentations on that, so I don't need to dwell into this further. But we know that we have made remarkable progress in terms of the sustainable development goals in many of the indicators, especially in the goal 3 of the indicators which we have considered in the morning. And southern state definitely at the forefront, that we have seen in many indicators we are much ahead of the other states. So, but there are also other areas of concern. So let us come back to the areas of concern next, please. So let's look at these slides and then see. I was sort of classified it into the different goals and then different indicators. So we have the target also in front of us, because target is set by the NITI. I have taken the NITI Aayog target because, if you really take the target set by the Ministry of Health, perhaps it is easy to achieve, and the little more harder target with NITI Aayog has helped. So we thought, our ambition should be a little more at the higher level. So let's look at the first one is percentage of households living in kacha houses. We need to make it 0. And, all the southern states and even India, uh, what I am really giving, giving at the last column, I think it is not clearly visible. Okay, in here it is visible at least. What we are giving at the last column is that, suppose we are progressing like whatever we progress between NFHS 4 and 5. So given that pace of progress is maintained, whether we will be able to achieve that target or how far we are away from the target. That is what by 2030 I mean. So the growth rate is kept constant at the growth rate we achieved between NFHS 4 and 5. So what's happening, if you really look at the first goal, even if you maintain the current progress, which is slightly not very good progress, but still we will reach something around all India level. We will reach something around 2.8% of the kacha houses, and but we know that the zero hunger, which is we are very very far off because we are in need to achieve 25.2 stunting anemia and 1.9 of the children's underweight and standard it is 6%, and adolescent girls anemic is 14 point. We are far away from at all India level because the current progress, if you progress, we will never reach anywhere. It means that unless you make extra efforts now, we are going to achieve anywhere to achieve the target by 2030 in the nutritional indicators. That's very, very clear about it. And what about the third, the goals, the health and well-being? So immunization, we will be able to achieve, even though if you really maintain the current progress which we have experienced between NFHS 4 and 5, we would be able to achieve the target even for the country as a whole. I'm sure state like southern state definitely will be able to achieve. There's no doubt about it. This is the case with institutional delivery. Definitely we will be able to achieve. And also the infant mortality rate, as I told you, infant mortality rate we may not take seriously because SRS gives you much better data. So we are always depending on that. We are also closer to that. Next, please. So what about the gender equity targets? Again, we are lagging. Look at gender equity target. We have to have physical violence by a husband of relatives, which should be reached to 0. That is the target which was set up. But if you go by the current pace, we will be something around 30%, almost same as the current progress. We are not going to reach anywhere in that. The sex ratio, definitely we want to reach 950. That 952 is the biologically determined sex ratio at birth. So the current progress, if you maintain, obviously we will be around that. So there should not be much of a worry in case we are able to progress. So the water and sanitation, I think the improved source of drinking water is not a problem. But if you want to really look at the pipe drinking water supply, which is also very, very low currently, I think we are far away from that. And the other two indicators, electrification and LPG, etc., we are right on track. So what does it really tells you with really looking at the data? After that, I don't want to show the state data because anyway, it will be. After that, I looked at the state level. What would be the conclusion I should derive if I look at the same indicators at the state level? Unfortunately, even if you really look at the state level of the southern states of country, we don't see any difference in conclusion what we derived from the all India level. None of the southern states will be able to reach the target set by 2020 on the nutrition status. None of the southern states will be able to reach this target, which is Center for Gender Equity. So ultimately, we will think, what is the difference in southern states? If you really look at, if you really want to achieve SDG goals, are the southern states significantly different from the all India pattern? Perhaps my conclusion is that not really. The only difference happens is that the timeline which we would achieve, perhaps it's different. Maybe some of the southern states may be able to achieve a few years earlier than the other states of the country. But ultimately, the issues are really same. We need to really take care of the nutritional aspect, which is really bad in this country, whether it is southern or northern states or any parts of the country. We need to take care of the gender equity part, which is really bad in this country. I think these are the areas of concern which we always look at. Next, please. I think I don't want to look in the next 4 slides, so because there are state level presentations. Next. Okay, so I would then planning to conclude, what do we really conclude from this discussion? In the most of the RCH indicators, I don't doubt, there is no doubt the progress is satisfactory, and it is likely that we would achieve SDG target and the current progress, if the current progress is maintained, there is no doubt. So that is not only true for the country, but even for southern state. And there can be some states which may be lagging, but even altogether as a nation, we will be able to achieve. But I think there are states which may achieve slightly later, but that is not a concern. But for the other indicators, I think where are concerns, whether, as I told you, indicators are closely linked to the health, whether it is nutrition, whether it is violence against women, whether it is non-communicable diseases. When we look at all those things, the situation perhaps is different. But in some of the indicators, we are almost close to the nation. But some indicators, like what we are presented in the morning on the non-communicable diseases, which you have some data. Next slide, please. Next. Yeah, we can see, some of these information also Nfhs gives you the goiter and thyroid disorders. If you really look at, this is highest in the southern states among the Indian states. And also you also already know in the morning that we have the diabetes and the blood pressure as well as other situations. We are really bad. And the screening of cancer is sort of negligible, which has been shown. So there are indicators where we really need to take much more care. Thank you so much.
Thank you, Professor James. I think that's a much needed corrective to all the rosy pictures that was presented about the southern states in the morning, and much more realistic, because there are serious concerns that southern states will have to address. But this is crucial area where I disagree with Professor James, in the sense that some of you would have read, one of the major indicators that distinguish a good state in India from, again, I'm violating my own in this thing, better performing states from the ones that don't perform so well is not natural resources, not any other indicators. It's a quality of governance. And I think that with that quality of governance, because all these indicators are not impossible, they can be done, provided the states decides that this is what we need to do. And I hope the states make that kind of a change. So to understand what the states are planning to do on this, I'll now call upon two states who are going to be with us today. Ratan's advantages at Ratan, while he's a mission director of Kerala, he was also a mission director of Karnataka. So, no, I will not ask you to present on Karnataka, don't worry. So, we will learn from Ratan as to how Kerala is planning to address the challenge that Professor James has flagged for us. Ratan.
Okay. All right. So technology is not with us for some time, but yes, we will anyway talk a little bit about what we are planning to do. In my presentation, what I was attempting to do was to, since it's a practice, a session for, I mean, it's a good learning session for various other states. Other states are looking forward towards the southern states. Some takeaways from this kind of a workshop. I'm coming to that. I thought at least let me start, by a good takeaway on how we are looking at Nfhs survey in Kerala. So that was my first attempt in my slides. And there are some takeaways for other states, definitely. In terms of what Sir just mentioned about good governance, there are other few parameters as well. And looking at the way in which we are progressing as a state, Kerala progressing as a state in terms of various indicators, there is definitely a cause of concern in some indicators. And that is what I was attempting to do in the last slide in terms of how are we looking at this data vis-a-vis earlier data. Earlier data, I wouldn't say only Nfhs 4. We are looking at from the inception from Nfhs of 1, 92, 93 onwards. We are looking at what are the
Good afternoon, everybody. Good afternoon, all the distinguished guests. Since it was a panel discussion, I didn't have a presentation. And my endeavor would be to highlight some of the recent initiatives which the government of Andhra Pradesh had taken with respect to the Panchayat Raj institutions and for the implementation of various health schemes and also for strengthening the village level institutions. So the first thing which I would like to stress upon is that what is the main reason for a Panchayat Raj institution not being functional, or the main criticism on why the Panchayat Raj institutions are not able to deliver is that in a village there are many functionaries. We say there will be a VRO, there will be a Panchayat secretary, and in some villages there may be a veterinary assistant. But if you see, the thing is that all of them are on their own silos. And so there was not in some states like Kerala, they have done in bringing some reforms into that, and they're very successful on that. But in many states, it's not so. So in Andhra, so our state under the leadership of the present CM, Shri Y.S. Jagannath Reddy Garu, had done this experiment, and it is working out very successfully. And what did we do? So in the village, so first is that we made a uniform structure. So in every village, what are all the functionaries they have to be there, we defined that every village will have a VRO, every village will have a Panchayat secretary, it will have an agriculture assistant, it will have a welfare assistant, it will have an engineering assistant, and based on the profile of the village, it will have an animal husbandry assistant or a horticulture assistant or even a fisheries assistant, and also an ANM and also a Mahila police to specifically deal with women related issues of domestic violence and all those things. Now, the interesting part to note all of this is that all of them have been recently recruited and they are permanent government employees. So for every village of a 2,000 population, we established these village secretariats. So every village now has almost around 10 functionaries who are working in the village. Now, having said this, having formed a structure, now in the second main problem what we face is that not bringing them under one umbrella. So what we have done in the Andhra is that now all of them have been brought under one umbrella, and there is a village secretariat, and a secretariat building is being constructed with the support of NRGS, and all of the functionaries sit in the village secretariat. So that has brought in the coordination between the various departments and for implementation of various programs. So that is one thing which I want to stress. Now, the second thing is that what we did is that linking the community with this structure of village secretariat. So what did we do? Our state, we have appointed a volunteer for every 50 households. There was a volunteer was appointed. And this person volunteer, so he brings the need of the people and he facilitates for them, including their health needs, and he links them up with the community with the secretariat. So these volunteers have been very instrumental during our COVID handling, because during the COVID, we did a fever survey linking these community volunteers and the ASHA workers. And we have done 45 rounds of fever survey. And these people go to every village and they will identify the symptomatic cases, and then they will be brought to testing, and then the isolation, the COVID protocol follows on. Now, this was very successful because these people were able to complete the survey within in 2 days of time. Entire state was surveyed, and we did this survey almost 45 times. We did this survey. Now, they have been instrumental in delivery of this home isolation kits and also providing them the requirements during the COVID time. And also they were instrumental in providing a home quarantine and also the village level community quarantine facilities also. These volunteers have helped. Now, these volunteers are being paid a sum of 5,000 rupees, though it's a honorarium. And they are now, linked up they link the public with all the welfare schemes. They deliver the pensions every month like that. Now, coming to the particular with respect to the health, what is this, what we have done in this Panchayat Raj institutions, and how is this interdepartmental coordination we are doing in this Panchayat Raj institutions. Now, in the village, there is an ANM and there is a Panchayat secretary. Now, now we know that there are during the rainy season and also during the monsoon season, there will be, there are sanitation issues or even otherwise also. So what every A&M does is every week we have designated a day, Friday, and the A&M goes to the habitation. She surveys the habitation and identifies spots of stagnation, and through her mobile, and then the sanitation issues to be addressed. And once she records let us say ticket, that immediately goes to the secretary of that particular village, and he has to redress it within a time frame. So this has brought in, let us say, inter-departmental coordination between the panchayats and also department and also the health, and through which our malaria cases have decreased compared to 2018 to 2021. There's about 30% decrease in the case of malaria. And now similarly, this A&M, when she goes to the school, she inspects the quality of the midday meal. She inspects the quality of the children in terms of their nutrition that is being provided. And then this feedback is being given to the welfare assistant of who is present at the secretariat. Now, this welfare assistant, she coordinates, or he or she coordinates with the school and ensures that proper nutrition is being provided to the children, and through the coordination with the headmaster. And similarly, if there are any engineering issues that is being present in the school, for example, drinking water supply is not there, it's not properly functional and all, and that is tagged on to the village secretariat, the engineering assistant who is present at the village secretariat. So by these aspects, so the preventive part is being very well taken care by this interdepartmental coordination. And more importantly, since all the people of the village are there sitting under the village secretariat, the sarpanch, let's say the panchayat elected body, he also sits in the village secretariat. And there is a leave sanctioning powers of this the secretariat employees, and also he monitors the attendance of these people who are coming, and we have a biometric system also whether these people are coming daily. So this has ensured that in the village the structure functions well. And also we the community the increase the community participation and also the coordination. What we have done is these secretariat functionaries, on a fixed day of two days of every month, these people have been designated certain households. They have been mapped to certain households, and they go to those households, link them with them, and also tell them about the various government policies, and also if they are deprived of any schemes, they will coordinate for that. So this increases the community, and also this Panchayat Raj institutions, the functionaries of these Panchayat Raj institutions. So through which we have been, there is satisfaction among the public with respect to grievance redressal has been very much. And every day, all these employees sit in the secretariat, and every day at 3 p.m. the grievance is redressed, and the grievance redressal mechanism is put, and so they receive grievances on a continuous basis. So this experiment we have done in Andhra Pradesh, and it has been working well. And so I thought I'll use this opportunity to tell about this before this August gathering. So thank you for this opportunity. Thank you.
Dr. Niva, somebody may need some clarification on your program. You can answer that and go. You have time? Please, if anybody, because they are trying with each state has its own way of making use of the Panchayat Raj institutions to improve the functioning of various departments along with health. And they have what he was stressing again and again. They are focusing to interdepartmental coordination, and then the role of health volunteers at the community level for 50 households, the role of ASHA workers, A&M, etc. He detailed. If you have got some clarification to get, please.
Thank you, sir. One small query. It's a very good model. I'm pretty sure it will be working very effectively. But those 10 people who are employed somewhere else, sitting in secretariat office, village secretariat office, what is the frequency of their sitting there and discussing local problems? This is number one. And number two, whether they are getting any remuneration for contributing to this, or it's purely voluntary social work.
So that's what I said, sir. Earlier itself, they are government employees. They have been recruited through a process, and they have been paid 15,000 rupees as of now, and they'll be regularized very soon.
And once they regularize, they will be coming into the regular government scale. So they are recruited through a process. And second thing is that they are mandated to sit in those secretariats. They are not supposed to move anywhere. They are all government employees and they sit in the secretariat. Every day they mark their biometric attendance and we monitor that also.
Yeah, it means that every village you are giving employment to 10 people.
Yes, sir.
For this kind of work.
Yes, that's true.
ICDS worker is also there.
ICDS, we call it as a Mahila police.
ASHA is also there.
That is already there. That is already under the Women and Child Welfare Department. Anganwadi worker is there. What I am telling is there is a Mahila police. We call her Mahila police. And she takes care of the Anganwadi centers. So every day she goes and inspects the Anganwadi center whether the nutrition is being given, and that is her major task. Second task is that counseling the women and also the adolescent women in terms of domestic violence and in terms of any eve teasing cases like that. So there is one functionary dedicated in every village for that in the secretariat.
So what is the total number of such employees? I don't remember exactly number of villages in Andhra Pradesh.
Sir, we have 10,000, we have 15,001 secretariats actually as of now. So we can easily put 15,000 into 10. It's around 1.5 lakh employees we have and 2.5 lakh volunteers we have. The volunteers which I told about, every 50 households we have. So we have 2.5 lakh volunteers of them. They are being paid 5,000 rupees every month.
In addition to that?
In addition to that, yes.
Oh, good health budgetary spending on this mechanism.
Yes, sir. So that's a good question, sir. These people have been, they have been told a very basic, qualification only, sir. 10th is what has been told. And the block development officer of that mandal, so he selected those people based on an interview. Since they are basically community people, sir, we didn't follow any test and all. So the BDO selected them. Yes, they have been given training, sir. So you said that the visit the schools. Yes, sir. Yes, sir. We have a school health program, sir, under RBSK a program where the medical officer has to go and also visit the school and also do the medical checkup for the children. But what we have done with the ANM is that now this ANM will go to the school on a regular basis. So she will go to the school and every, every Thursday we have now made it mandatory for her to go to the school and determine about the midday meal and also about the anemic status of the children, giving about the iron folic acid tablets. So that we are monitoring through the ANM.
If there are no more questions, yeah, please.
My doubt was that how are they connected? Because you have a government system now, you are recruiting some 10 people. Are they connected directly to the central office in the secretariat, or is it in between the panchayat system comes into play? So how do you really do decentralization there?
Yes, sir. So there are two kind of things we have done here, sir. So, for example, what the employees have to do, for example, what is their job chart? For every employee, they are tagged on their own department. Like, for example, the Mahila police, it comes under the Women and Child Welfare Department. Agriculture assistant comes under the Agriculture Department. Those departments will specify them what is the job they have to do. That is one, sir. But what we have done here is that we have formed a separate department, that is GSWS, Gram Sachivalayam and Ward Sachivalayam department. And this department is taking care of the entire, these people, their attendance, their HR, everything is managed by this department. So individually, the instructions come from the department, but whether they are sitting at that place, they are marking the attendance, their HR part, that is separately handled by this GSWS department. So in that way, we are able to achieve this kind of coordination, sir.
But how are they related to the panchayat? Panchayat must be having elected councillors. Now, how does that come into the picture?
Yes, sir. So that's what I told earlier, sir. In the village, so every village, the secretariat, what we have done. So these secretariats are established for every 2,000 population. The panchayats, maybe some of the panchayat population, maybe 5,000 or 10,000. So, but these secretariats are co-terminus with 2,000 population. So one panchayat may be having, let us say, two secretariats also. Sometimes one secretariat may be involving two panchayats also. Now, what we have done is that in the village secretariat itself, there is a separate room for the village sarpanch. So he comes and sits there. Basically, the idea is that the village panchayat institution, the sarpanch, he should come and sit there and monitor whether these functionaries are working. And that's why even the leave is also being proposed that should be sanctioned by the local level panchayat raj institutions.
Thank you very much, Nias. We shall continue with the proceedings. Okay. I have to make some initial comments, which I will do standing. But I have to give a warning that these flowers they are real flowers. So that it is frightening me to some extent because I am an asthmatic and these pollens can initiate an acute asthmatic attack. And in case I develop an acute asthmatic attack and fall down, please don't, there need not be a commotion here. I have kept a steroid inhalation in my pocket in anticipation. You can use it to revive me. No, thank you. Well, my initial remarks with regards to decentralization in healthcare, especially after the Panchayat Raj institution has come to stay in this country. And it was quite appropriate at this time to discuss this because in Kerala, the first election was held in 1995. And therefore, this is the silver jubilee year of the Panchayat Raj institutions in Kerala. So it is quite appropriate to have a look at back. What were the problems which we faced? What were the debates we had? And also, I am sure that my three colleagues who are public health experts will be looking at these things. But you know that, interestingly, the decentralization in healthcare was always a contested issue, interestingly, even though everybody welcome it now. And of course, we are trying to make it a success. It was a contested issue. There were two divergent views if you look back at the literature. One group supporting the decentralization of healthcare, the other view, the detractors questioning some of the basic premises. Those who said that decentralization is going to help in health used to say that it can promote local ownership. And of course, it can then of course you will respond to local needs. In fact, between states and within state, between various places, the health needs are different. So local bodies can naturally respond to these local needs. And moreover, you may have better availability, more availability of resources will be there, etc., etc. So this was what being said at that time. But nevertheless, there were critics who used to say, which still is there. There are people who question the very idea of decentralization in healthcare with some modifications. They used to say that this can weaken the health ministry, because the health ministry at the national level and the state level will have their own public health policy. And once the local bodies also start implementing their own programs, naturally there can be a chaos and confusion. And it is quite possible that the local desires need not be in line with the public health concept of the state or the national level. Because I am sure that we were taught in the community medicine department. When I was learning medicine, that was in 1965, you know, most of you were not born at that time. I think none of you were born at that time. We used to say about the contradiction between the real need, felt need issue. The real need of the population may be different from their felt need. And from their conventional wisdom, a local population may ask for a hospital to be built there, whereas the need may be a portable water supply, etc., etc. You know that. So therefore, this can come into conflict with national level policies. So it can weaken the Ministry of Health. And moreover, it can create unrealistic expectations from the people also. This is happening in Kerala. In fact, the other day I was in my native place, and the people came from there, came and asked me to put pressure on the government to establish a cath lab in their local area. So there such high expectations can be there, and there can be a failure of allocation of adequate resources. The local self-government institutions themselves may be neglected in a centralized governance system. So this was some of the points which the detractors have raised, which still holds good. Some of these arguments are still valid. But nevertheless, uh, there were those who said we can decentralize conditionally. They started putting forward certain conditions that there should be a systematic health planning, even from the national or state level, taking into consideration the fact that there is an element of decentralization that is taking place. And secondly, we should have a functional supporting system to the local bodies when they do health projects. They are totally inexperienced. They are not used to do this type. In any sector, this is true, but more so in the case of health. And also, they should be able to have some experience in management of financial and human resources. It's a major issue to manage the human resources at the local level. And because all these were managed at the centralized system, because the doctor will have to answer to the Panchayat president. And this was one of the issues which was very much debated in Kerala. And then the pharmaceutical supply should be ensured. And moreover, we will have to concentrate on skill development at the local level. This is extremely important, in the absence of which this may not function. Say, for example, the healthcare providers are now going to act as the managers of this system. Earlier, it was not there because it was a vertical system. They were just implementing the projects that were decided at the higher level. But now they have to manage it, conceive these ideas. This needs some amount of skill development. And secondly, the local community managers, members themselves need some amount of skill development when it comes to governing such healthcare institutions. And moreover, they should be aware of the health issues facing the country or the state. They may have some innate wisdom which need not be the solution to the health problems which they are facing. Interestingly, I came across with a document after we started implementing the decentralized planning in Kerala. We started implementing it in 1997. We started implementing what is called the People's Campaign for Decentralized Planning. At that time, I was a part-time member of the State Planning Board also. In fact, the initiative came from the State Planning Board, led by Dr. Thomas Isaac, who later was the finance minister. And during that days, I visited the Medical College Library here. It's a very good library in Trivandrum Medical. I studied here. And I happened to come across with a WHO document, which I think is highly relevant. And everybody who is interested in public health should read and reread this document. This document is titled Community Involvement in Health Development, report of WHO study group published in 1991. Very interesting document. What they were trying to say is that if you want to solve the health problems of the developing part of the world, especially the developing part of the world, you will have to ensure community participation. Of course, this is a well-known concept, nothing new about it. But they went on to say, I am quoting, a critical step to ensure community participation will be the decentralization of health services. It's exactly the word they have used. And that will serve as the basis for community involvement in health. They further went on to say, this is the most important part, which took me by surprise, that structural changes in health system will be necessary to support the community involvement in health process. These changes include decentralization of planning, management, and budgeting. So they have stressed these 3 points. We will have to not only see simply saying decentralization in an abstract way is not enough. You will have to decentralize planning, management, and budgeting. This is exactly what we did in decentralization in Kerala. The uniqueness of decentralization planning in Kerala is that we not only decentralized the departments, of course, that itself was unique in that we have handed over health facilities up to district hospitals, the local bodies. This has never happened anywhere else. I don't think so. Anywhere else it has happened. The primary health centers were handed over to the Gram Panchayat. The middle order hospitals or sub-district hospitals were handed over to the block Panchayat, and the district hospitals were handed over to district hospitals. Okay, this has happened. So decentralization of management is okay, fine. But that is not enough. At that time, 30%, 30% of the budget allocation was given to the local bodies. In fact, when the finance minister presents the budget, there is a separate part which allocates specifically this particular panchayat will give this much amount. There is a parameter by which they decide on the amount that goes to each panchayat. So funds were transferred. Of the funds that the panchayat receive, 40% they can utilize for social services, health and education and other social services. And third and most important is that they can decide at the local level how this should be spent. This planning was also decentralized. This is the unique way in which decentralization happened in Kerala. And this helped us a lot. I am sure that my colleagues will be discussing these issues. Number one is that, see, everybody was talking about Kerala model of healthcare from 1950s onwards, 60s, 70s. But Kerala was facing very severe crisis from early 1980s. Kerala is a highly morbid society. This morbidity can be explained to some extent. Maybe it is a price we are paying for our success because the longevity is increasing, death rate has come down. And naturally diseases, non-communicable disease can increase, diabetes, hypertension. But it was more than what we expected. Kerala is the diabetic capital of India. More than 25% is the latest figure, more than what we expected from a community. And along with that, there is an infectious disease also prevalent in Kerala. That is a tragedy. Even people are dying of H1N1 and leptospirosis in Kerala. Leptospirosis, which can be treated and prevented with using very cheap doxycycline. People are dying, of course, in lesser numbers maybe compared to other states, but it is happening. So in this situation, the public health system was stagnant. It was not expanding to confront this increasing incidence, morbidity. And moreover, specialization was developing. More new technologies were coming up. In fact, I completed in neurosurgery training in 1982. I did carotid angiogram. I was not exposed to CT scan. CT scan came to Kerala in 1986. So the public health system was not expanding. In fact, in that vacuum, the private sector came in a big way. In Kerala. In fact, when I completed my MBBS in 1971 from Trivandrum Medical College, there was hardly one private hospital in Kerala, in Trivandrum. But now Trivandrum is oversaturated with private sector. To that vacuum they came. And the first CT scan was established in a private sector. The first cath lab was established in a private sector in Trivandrum. The first dialysis center was established in a private sector in Kottayam. Earlier, all the tertiary care was taken over by the government medical college. That shifted. So it was at that time that the decentralization happened, the very most appropriate time. I am not going to the way how this happened. And what happened was that up to district hospitals, local level, self-government institution, along with the health department could manage, they improved their functions so that the health department can now concentrate on the medical colleges. In fact, at that time, we used to say that Kerala model was changing over to an American model in its good and bad sense. What is the goodness in American sense? All the high technology care is available. The bad thing is that about 30 million people are denied health care. Something like that was about to happen in Kerala. Poor people had no recourse to go to the government hospital. Facilities were poor. Rajiv Sadanand mentioned about this earlier. But then the decentralization came. Now the present situation is that at least 70%, do you agree with me? 60 to 70% of the people at least are being catered by the public health system, and the eminence of the medical colleges, government medical colleges, has been recaptured. But there are large number of issues yet to be solved in Kerala. The morbidity is still there. Now, one thing I hope that my colleagues may respond to my initial remarks is that we have given thrust to quality care, but the health education and health promotion has been neglected. You go to the primary health care centers, the PHCs have improved, but the sub-centers are not functioning properly. So that is my worry.
But meanwhile, the wellness clinic is going to be implemented by the national government. So the health promotion is what is needed in Kerala at this point of time. Because the prevention is better than cure is still holds good even in Kerala at this point of time. But decentralization of healthcare has definitely improved the way Kerala was moving towards the American model. We could shift back to the dominance of the public sector in Kerala. That was very well evidenced during the COVID pandemic. In fact, we could manage the COVID by 95% of the patients were treated free of cost in government hospitals in Kerala. And if you disaggregate the programs that were implemented during COVID, suppose there are 10 programs or 100 programs, 75% of them were implemented through local self-government institutions. If you look at the contact tracing, you look at the way the first line treatment centers were established, how home isolation patients were taken care of. We have ward level committees, mostly run by the local self-government institutions that could succeed. In fact, the success of COVID management in Kerala is more because of the existence of local self-government institutions rather than due to the health department. Of course, both work hand in hand. So that shows that the effect of community participation in health. Because as WHO told in their very important document, the community participation could be very well realized in Kerala because of decentralization. And it is because of the decentralization process and handing of these health institutions, the local self-government institutions, that Kerala could recapture the eminence, the leading role of the public institutions in Kerala. These are my initial remarks. And with these few remarks, we have three presentations here who are very well, highly experienced in their field. Dr. Vijay Kumar will be making the first presentation. He was the professor of community medicine in the Medical College Department, now retired. But he is an health activist also associated with the Kerala Shastra Sahitya Parishad, the people's science movement in Kerala. Dr. Vijay Kumar. Good evening, everyone. I didn't bring any presentation because of certain communication gap. I'll be speaking from whatever I have prepared just now. The role of local government in the health sector in Kerala, it's a very broad topic. Thanks to Rajiv sir, we have recently carried out an evaluation in that particular field, how it has contributed to the development or maybe retrograde. The decentralization has impacted the health sector. I'll just focus on some of the advantages and strength of it, and also maybe potential areas where the local government can work with, and also the limitation as we have studied. One of the major achievement, as Dr. Iqbal has pointed out, is that the implementation. Actually, the local government became the agencies of the state or the center, where the implementation of any program was made better, made more efficient. Actually, when the program started in 1990s, late 1990s, one of the slogans, or maybe the songs that we used to sing, was that the ruler as well as the subjects, we are the rulers, we are the subjects. It's entirely upon us to decide what we have to do here and now. It was such an ideal thing. In fact, I used to sing in the street. But that sort of interest, it was really a dream, but the things didn't actually go that way. But still, in fact, during those days, HIV was actually spreading like anything, and the state has come up with AIDS control program. it was the Grama Panchayats and district panchayats which took the initiative in ensuring that stigma is fought in the street. Till then, it was the role of the NGOs, or maybe some of the NGOs, not even actually more. Many of them were working, but panchayats came forward. They came forward to rehabilitate the victims of the patients by providing food and other supplementation. Then again, the next one was tuberculosis. Control of tuberculosis. The program was there actually. Short course chemotherapy was introduced in 90s, and then the medicine is there, but at the same time there were a lot of TB patients. Many local government came forward to see that the patient load is actually brought down. Similarly, say in 2005-2010 period, Kerala had dengue and chikungunya epidemic. It's something like wildfire, But at the same time, it was specifically targeted. The local governments were oriented, and maybe Rajiv sir is here in Alleppey. We used to get frequent episodes of waterborne diseases and vector-borne diseases. Targeted intervention, the local government could do something which the state machinery couldn't actually afford to. They have done something new. They have actually carried out something beyond the reach of the state machinery. When we speak about the reaching the unreached, please understand that it was not uniform. I'll just elaborate it when I speak about the limitations. They have achieved something so that it could actually sustain this activity, and the later, the COVID and all those things was actually a growth from that sort of interventions. Similarly, during the flood, everybody, including myself, was predicting that we are going to have lepto immediately after flood. Distribution of doxy was really good in the sense we didn't get that much of cases over there. So these are all these certain implementing. Say they were actually implementing efficiently and to the peripheral most part of the panchayats. They could also bring together different domains, but here there is a little bit of weakness is also there, but still much better than the state government agencies. The local government were able to bring together education, agriculture, health, and social security. So it's not to the extent which I would love to have, but at the same time, they were able to bring these services together. Recently, I was working with some of the panchayat and see at least some of them were boldly saying there's no hunger here, not the micronutrients, macro. Nobody goes without food here. There will be food for everybody. This sort of achievement, I do not know how many geographical areas in India can claim that sort of a thing, hunger free. Everybody is assured of food. There are, in some places, there even now it is a problem. So this was achieved because of the successful coordination of different agencies, different development department, local NGOs, and community-based organizations like Kudumbashree in bringing together to deliver these goods. In fact, it was the 2005-2010 period, you find that the rise of the bud school in Kerala. For those who are outside the state, I will tell you, the bud school is actually schools meant for mentally retarded, mentally challenged, or cerebral diplegia and all those disabled children. They were actually unseen in the domain, public domain, because these people cannot walk and they will be within the home only. Every panchayat had like 50 to 100 such children during those periods. And the panchayat it was not a government initiative. It was an innovative program which actually the local government had tried to develop based on the local demand and maybe local using local resources to address that issue. That's how the birth school came. You might have noticed now they say now the open defecation free panchayats in India, or districts in India, states in India. And at the end, you ask what proportion of the people are using toilets in open defecation free districts. But Kerala, the scenario was different. Even before the onset of such a program, you'll find that say 78 we studied the conducted survey, and over the decades what we find is that use of toilet and provision of toilet was actually exceeded our limit, our expectation with the onset of the functioning of the local government in 2001 to 2005. So whenever the national program came in, it was actually the final lap which they have to actually cover. The local government acted as actually a link between the state and the public at large. The local leaders were very very close to the people, and they could actually feel the suffering of the people. Therefore, it was they actually who started a program for NCD, especially diabetes and hypertension, even before the central government and the state government started in that domain. That principle was actually integrated with the state going for the NCDs in 2005-10 period. The other one was 2003-4 period. At the same time now, because of time, I just restricted. So many areas needs to be addressed, and this need can be done only through the local government. That's what I feel. The behavioral change that we require. The previous Nfhs finding, which we had seen in the morning, says 30 to 40% or even 50% people are getting obese, and the corresponding consequence of that obesity. To bring in behavioral change, we require the local government. As Dr. Iqbal was saying, health promotion or promoting exercises, dietary changes, and all those things. Nearly 20% of the population of Kerala is more than 60% now. 60 years now. So far, we do not have any program, because I am also a person beyond 60. So far, we do not have a program to address that big proportion of people. You may recall that in 1975, under 5 children were 15%. We started with 30 Anganwadi workers per panchayat. Now, under 5 is only 5% or 6% in the state. Elderly is 20%. You do not have a program, do not have any designated functionaries to address the service requirement of such a great segment of the population that we require. The gender. Here again, is more often said, but practically, somebody was saying about the violence or the status of women, empowerment of women, even their work participation, income generation, and so many other malaises like dowry, death, and everything. Services are there, potential is there, but still the local government will have to move a lot in that direction. The major limitation that we have identified is that many of the panchayats, district panchayats, maybe Nagara Safas, even though they were handed over the institutions to them, many of them couldn't have the competency or the vision of running big institutions like district hospital or taluk hospitals. By and large, even social security or elderly homes and all those things. So institution running is not their cup of tea, and they have done a lot, they have invested a lot, but if you go and evaluate, you'll find that a lot of things needs to be addressed. And many often, good proportion of the local body did not have actually a comprehensive approach to healthcare, basically because the program will have to be project will have to be discussed in the population. They need to get the approval of the people. But these are all the theory which actually I'm sure that Dr. Joey is also teaching them. But most often how it is actually formed is an overnight telephone call to medical officer or a health inspector. Please prepare a project, something like that. And the e-health portal of IKM, it also doesn't require any clear, precise projects. Yeah, one line, maybe welfare of elderly or women, something. You put some budget and it is gone. It doesn't actually communicate what exactly what. It was not the case when 9th plan and 10th plan, but now that's how there is where we have actually reached. The projects are actually not developed in consultation, appropriate consultation with the people or maybe the different professionals. It became something like a ritual. 2 minutes, 1 minute. So the continuity of the program in many of the government, local government is challenged. There's corruption. Monitoring and evaluation is not existing most often. And public health failure of the public health professionals. Today, one of my great friends actually came to me and said that they are preparing projects for women health. X, Y, Z doesn't sound any good. Basically, I found it the want of the health system to warn it up and orient the medical officer of the PHC or Taluk hospital to develop program what the health system wants. For want of that sort of ownership from the health system side, the program quality is not actually getting up to the point. I stop with that. I'll be going on speaking more and more. Thank you for the patient listening, and I thank all the organizers for giving me an opportunity to come and speak with you. Thank you.
Dr. Joey Laman, who is the Director General of Kerala Institute of Local Administration.
Distinguished guests, friends, colleagues. Actually, it's an opportunity for me, and thank the organizers for inviting me to this conference. I tried to make it in three phases or stages, which I would like to. The session 1 is about what Dr. Gibba started with, about the decentralization and the local government system. Because here it's all about statisticians and demographers and health professionals. I think everything starts with the baseline. And in 1996-97, when we started the People's Plan campaign, what was the baseline? Dr. Iqbal hinted at that. It was the time when states were supposed to back out of health, education, and similar sectors. We started in the 80s, and the impact started coming up in the early 90s. I remember Dr. V. Ramankutti's paper, the copy of which he himself doesn't have now, where 90% of the health expenditure was only for the establishment and continuing this thing, and only just 10% for further development, which has its natural impact on the system, where the health system was getting degenerated, stagnant, and no scope for moving further. There is no alternative was that slogan, because it's a global phenomenon, national phenomenon. And so Sir also said, there is no alternative, Tina. And then Kerala said, there is alternative, TR. The government should not get out of it. Rather, government should get stronger on it, move closer to the people. And that is why we tried to strengthen local governments. One of the tools used was the People's Plan campaign. And even when we say decentralized planning, actually we don't do decentralized planning, we do multi-level planning. And it comes with a lot of limitations, because when you do multi-level planning, the need for convergence, need for bringing together, all these things were there. To cut it short, after 25 years, now we are celebrating the silver jubilee year of the People's Plan campaign. What is the result? Sir again hinted at it. Instead of moving out or the stagnation of the health system, what we find now is a strong public health system, which you mentioned about 70 to 75% actually once in a while visit a public health care center, in whichever way it is. Not that, my point is that from a stage where the health system, public health system and education and all similar systems were in struggle, the local governments brought back the agenda of public health and public health system in the foray. And that showed clearly the impact during the COVID times, when almost, you said 95%, okay, I agree with the 95%. The entire management of the COVID was taken care of by the public health system in Kerala with the support of the local governments. So that is the kind of change or the impact the decentralization of health, decentralization has brought in Kerala. And the difference is that it was not just the decentralization of health system, but it was the decentralization of the entire governance system, where all the proximate determinants of health were also to some extent managed by the or decentralized at the local level. So this is the first part of it. So basically, it is a multi-level planning, not the decentralized planning, where people interact. So there is a dual control where the institution has been transferred in one way, whereas there is also the other levels of health system governance also. But of course, all other sectors which contribute to health are also coming together. That's the first part of it. Second part, I thought, because we are discussing the National Family Health Survey, definitely the family health surveys have been revolutionary in its nature, especially the district level disaggregated indicators and data, which has been of much use for policy making at the district level. But now it can be linked to SDGs and SDG planning and monitoring. And that has also been seen in the aspirational district phenomenon and initiatives and all this. But we need to get it disaggregated further down, and where probably the small area estimation procedures could be adopted. Dr. James has to tell me. I don't know much about it, but probably we need to think about small area estimation procedures to bring it down to the panchayats and down to the local governments, which will actually bring a little more scope of linking with programmatic changes at the local level and also the financial allocations at the local level, because we do people's plan where allocations are made. It's okay. And there is also the advantage that we need not go in for several rounds of surveys. What we find is that for every scheme, every program, every project which you make, you again go for a survey. We don't have to do, if we have the locally disaggregated data from the Nfhs, most of the things can be taken care of, and just add to that could be the Mission Antyodaya data, which again brings in a lot of indicators, and then that can be done. So there is, and this Nfhs data actually can be used by the panchayats and local governments for monitoring purpose also. Usually what we do in monitoring is of the outputs, what we do and what we achieve. Whereas the Nfhs data actually shows us what is the result, what is the change. That is the advantage. But then I would request IIPS to encourage utilization of the Nfhs data at various levels, not only at the highest levels, up to the local level, where I would say all these discussions usually happen with the elite circle of experts and people like us, whereas we need to take this Nfhs data down to the local level, provide the expertise, handhold, probably, usually I use the term, synthesize it in such a way that it can be assimilated by the people at that level. So that kind of challenge, I think we have, where I request IAPS to start working on that. Kila will be there, my institute will be there with you to start a pilot in Kerala, how to actually localize the NFHS data for planning, monitoring, and implementation. So that is there. And here, I would also like the third part of, okay, if it is okay, we are there with you. And we are actually willing to work with you, get your expertise to localize the NFHS to the local level. That's the thing. And the third part of my presentation is actually on the SDGs, where again, NFHS data would be of much use. And there we have started to do something called the localizing SDGs, where local indicator framework has been created for Kerala. Initially, we created for Kerala, and then now the Ministry of Panchayat Raj itself has taken it up to the entire country level. All the ministries have come together. And okay, so when we tried the local indicator framework, see, because these global indicators are there, the national indicators there, but then most of the times for a panchayat there, this cannot be, first one. Okay. So it is basically for planning, monitoring, and implementation, which I said, for achieving SDGs. Next one. But the problem we face at the panchayat level is that might not be applicable. All these indicators might, because there are around 349 indicators, it will go up. So might not be applicable locally, do not match real local realities. Most of these definitions do not fit, because even we cannot understand what it means at the local level. Non-availability of data, we say it's all there, but no department, no institutions provide data to the local level. And inaccessibility and validity and reliability questions are there, and also cannot be computed at the local level, cannot be disaggregated in many situations, cannot even be understood by the local people. However, many of these targets which you mentioned have to be achieved by actions at the local level, or they add to that. So what we did is, we tried to tell the panchayats, some of the panchayats, you take the entire list of indicators, all these, whichever is applicable, but a few of them from the main list would be applicable up to the local level. A few indicators can be slightly modified. For example, if you are talking about the IMR, your denominator is 1000 libers, and you cannot do anything with the 1000 libers denominator for a panchayat. But then they can say that we are not considering this IMR, but you are only talking about how many number of infant deaths happened last year or year before and the year before. For a panchayat to plan, this is the only thing needed. They decide that our target is, we don't want any infant deaths. Or even the case of mortality ratio, again, your 1 lakh denominator doesn't fit at all. I think that is the case. So that is slightly modify your indicators. A few indicators have to be added, because when they do their planning, they need to add. A few to be totally deleted at the local level. And they map the status. Gaps to be identified. They set the targets. They decide the milestones. And finally, all lead to achievement of SDGs. You may compute it at the level of the district or the state or the nation, but you do it locally. That's it. So this is it. Next. So this is how we did. Say, for example, the National Indicator Framework talks about proportion of population living below the national poverty line. For a panchayat, it is not about the proportion. Number of people living below the national poverty line is just modified. And they need to get these people above that. We just did the extreme poverty assessment, and they came up with 64,000 people with extreme poverty. So something like that. Some of them have, say, poverty gap ratio. They delete it because they cannot compute all this. So this is the kind of, just an example with the time constraints. So we did that exercise. Okay, next. So some of these new things were created also. Okay. Now, see, local government process, panchayat process already have a situation analysis. National level also now there is a GPDP, the Block Panchayat Development Plan, the District Panchayat Development Plan, where they have to do a situation analysis. A status report has to be prepared. They can simply use the Nfhs data for that. Consider all the various SDG themes also. For every SDG, the local government can prepare a base scenario and the indicators, and then they can do it next. Working groups and all these things. I don't want to go into all those details. That is the process. Next. So we also created a dashboard, local dashboard, which can be used by the panchayats. Next. So this gives the final situation. Every panchayat can actually work on it. Next one. Where there is a national, this thing, they can actually change the indicators. They can modify the indicators. They can delete the indicators. They can set their targets. They have this thing. They can set the targets, and then they can plan for future. So this is the something which we have created, and we are into it. And the Ministry of Panchayat Raj has actually taken it up, and now they have created 9 themes. In Kerala, we do the 10 themes. For example, there is a healthy village. So where we are not going to tell the panchayats about goal number 3 or 4, 5, nothing like that. We are only taking that, what do you want to achieve in health? Where they say, we want everybody to be healthy. And that's your healthy village. And then you take care of all these indicators, and whatever targets you fix, the projects are for achieving these targets. And finally, the Nfhs data also has a household level information, which means some of these SDGs have to be achieved at the household level also, where we are initiating a program where Kudumbashree, the neighborhood group movement in Kerala, have started working on localizing SDGs up to the local level, where some of these SDG indicators which are directly related to health. For example, I can tell you a couple of things. Just 1 minute, sir. One, we need to achieve this at least 12 hemoglobin HB12, where we are actually behind. Kerala is behind. Am I correct? The health people? We are behind, especially for the women and the adolescent girls. And we need to achieve this 12. In a neighborhood, they discuss and see how many of us are below this 12. And then my goal is, target is 12. And some of the things can be done at their household level. Some, of course, has to be done at a higher level, but one step forward. Or you take the case of a Anganwadi, where we have the growth charts, where we have those 4 colored lines. How do you take the number of children in the red line to green? Many of these things can be achieved at the household level also, not just the supplementary nutrition, the Anganwadi. It's also to do with the household. So some of these things can be done at the local level. Some of the things can be at the household level, some at the ward level, some at the panchayat level, and then to the higher levels. So this is something which you are trying. Basically, the approach is about a thematic approach where the indicators become very useful. But the thing is, as I told you, we need to take it down to the panchayat level and handhold to use the data. Thank you.
Thanks, Joey. Now we have to hear Dr. Dahar Muhammad, who is the medical officer of the Family Health Center in Nulpuzha, Wayanad, one of the backward place in Kerala. And I was fortunate to visit this FHC. Yeah, before the COVID. I have a dream, Muhammad, which I will tell them later.
Okay, sure. Good evening, all. This all spoke about the policy making, the importance of local self-government in health institution. I got a small chance to implement few projects in my institution, that in Wayanad district in Kerala. Few words of my panchayat Nulpuzha. We are the only panchayat in Kerala sharing 2 borders, 2 states. One is Karnataka and one is Tamil Nadu. Of total population, 45% belongs to tribal community and 3/4 covered by dense forest. And we have frequent wild animal attacks in the colonies, everything. So you can imagine the people in Nulpuzha Panchayat, they have no other health institution like modern medicine. They have to access only this institution. So, Raj sir is there. The Ardhra mission, it was a platform to the LSGD. How to utilize the LSGD for the development of a health institution in a panchayat. Just change. Just already shared. Change. This is the my PhD view in 2016. I don't think it won't look like an hospital. Look like an like what to say cattle shed. These are OP block, and 3 doctors sitting in the same room, and each development this hospital related to the SDG goals, and the main thing is health status report of that panchayat. Change. These are the some old pictures. Stop here. This is a picture. There's no smell coming out of this. These are bed used by a tribal community. And if you go to that ward at that time, 2016, you'll close your mouth and say, you can't enter because smell of urine. This was our ward. Change. Photos. Change. Yeah. This is a laboratory. How a patient, NCD patient, can go to that lab and give FBS? I won't go. Sure, damn sure, I won't go there. Change. This is our dressing room, and this is our spotlight. If you want to adjust that area, the nursing assistant will have a rope is there. She'll pull the rope to adjust the area, to focus that area. Change. Her ward, where the patients, especially tribal community, come for treatment. Our toilet, everything. Change. The beginning of change after Ardhra mission. So, changing. How we can utilize a local self-government for development of a panchayat? As they are all told, because 30% of the budget they're giving to local self-government. So after the implement of Ardhra mission, I've studied what are the funds available with the local self-government. There are different types of fund available with local government: plan fund, maintenance grant, non-road, Central Financial Commission grant, World Bank grant, and then Panchayat own fund is the general purpose grant. Is different types of fund is available with the local government. But how to utilize this fund to the health sector? How to make them to spend that money towards the health sector? It was a big challenge. There we need we had Grama Sabhas, where this basic data is discussed in the ward level activities. So we'll make our health inspectors, like our ANM all, make people to comment in the Grama Sabha that these health institutions is the poorest in this panchayat, so we need more fund. If I ask the fund, they won't give the fund to me because I am a government servant. If the public asks the fund to the elected members, they can't avoid it. So what I did is, I convinced the public, each ward, that this is the health issues in this ward. So you should speak the truth. And you should ask them to give fund to that health institution. So we are getting a group of comments from 17 ward. So automatically, this Grama Sabha decision is discussed in the health working group. And I am the convener in the health working group. So as I write, yeah, this is the points to highlight. These are the major issues, health issues in that panchayat. So after that, after making the draft project, again they'll go to discussion in the Grama Sabha. So they will be happy. After 10 project, they accept 5 to 6 project. Okay, we are happy because we have another time is there. We can implement more project. That way we developed the institution, both infrastructure and the service and the quality change. If new, let us change. Change. This is our reception area. This is our COVID kiosk. This we implement during COVID time to save HR. This automatically monitor the temperature and patient can have sanitizer everything. So our reception area. Only one thing, as we told later, that why people are not coming to government hospital. One is crowding, one is poor quality, and the infrastructure. Because if you go to a corporate hospital for fever, they'll give paracetamol only. If you go to primary health center in Kerala, anywhere for fever, they'll give you paracetamol only. But the way of giving, that we have to change. The treatment protocol is same everywhere. But the way of giving the tablets, that we have to change. For that, we need support of Panchayat Raj. Change. It's our reception area. Change. For here, we implemented here first time in Kerala. Thank you, Rajesh, once again. Because it was a big task for us that time. It's a secondary waiting area. Change. This is our pre-checkup area. Wait there. This is our primary waiting area. This furniture is made of bamboos. Because I told you before, most of our patients coming to our belong to tribal community. So they like this furniture. So make them patient friendly. So we had a project how to make our OP department patient friendly. So we implement with the help of the Panchayat LSDD fund. We purchase this through our Panchayat. Change. This is our OP block. Change. Wait there. See, this is our OP department. You can see the doctor's chair and you can see the patient chair also. In typical hospital, what will you see for patient chair? Like a steel, like one chair will be there or one wooden chair will be there. The patient will, when will sit that, it may fall. Make them comfort. Let them comfort first. Then they speak about the complaints. So we made our hospital friendly with the help of our Panchayat. Change. This is our new lab. You can imagine old photos. Change. This is our new laboratory. And we had good support from LSDD. And later we extended with the help of Panchayat because we need more fund for developing the hospital. So we go to CSR, bank fund, everything. Change. See, from your start, he is a patient about, I think, 70 years. He's a geriatric patient. He came for NCD clinic. So he needs a comfortable chair. So in Panchayat, the different category funds are available. It's mandatory to keep that fund, like palliative care, women and child care, geriatric care. So I told that Panchayat, I want to make my hospital geriatric friendly. So they're forced to give the fund which is allotted in geriatric category. So I purchased a chair comfort for a geriatric patient using not common fund, using geriatric fund. Change. Sir, pharmacy all, everything health related. Change. This our, you can imagine the previous photo of our medical ward. I changed to now, like 3 years back, we can see only auto rickshaw in my hospital. Now we can see Audi, BMW, people coming to hospital for taking the treatment from my family health center. Change. We having excellent medicine department, everything. Change. It's our dressing room. Change. Just this all the changes we made with help of LSGD. Change. Sir, 5 more minutes. Change. It's our vaccination room. And there's a small TVs there. That right side. That will put Tom and Jerry cartoon, Dora Buji, everything. So when it comes to vaccination, I can see cartoon also. This IUCD room. Bye, change. So office, everything, change. So our conference hall, innovative projects come. Wait. As we discussed, everything, any project we are implementing
Thank you to all the panelists for such a fruitful discussion. Thanks a lot. And I hope this memento won't harm anybody. So with that, we come to the last session of today's workshop, that is on state-specific issues and best practices. So do we have some states who would like to make some presentations? Is there any state who would like to make a presentation? Yes, from which state? Karnataka. Okay. Karnataka, sir, would like to take some time. Anyone else? Telangana. Okay. Then we can take a tea break. Yeah. So we'll come back after a quick tea break. Just reconvene maximum after 10 minutes. Right. We'll start the session at 5 o'clock. Please reassemble. We'll be starting the state presentation soon. It's already 5 o'clock. Please be back to your respective seats. all of all of those who are outside the hall are please requested to get back to the respective seats. Let us reassemble now. We are already running short of time. All those who are outside the hall are requested to get back to their respective seats. So BJ, request everybody to get back inside. क्या? अरे अभी कोई वो भी तो नहीं है जो IAPS के लोग. So now it's time for the state-specific presentation. So the first state, what is the state name, ma'am? Telangana. Karnataka. Karnataka, right? Okay. So first we would like to request the state of Karnataka to give the presentation. Oh, it's there in the system? Oh, आ गए हैं. So for making the presentation for the state of Karnataka, we have with us Dr. Parimala, Director, National Institute for Health and Family Welfare.
Good evening, everyone. This is Dr. Parimala. I'm Director, State Institute of Health and Family Welfare, and Executive Director, KSHSRC also. Yesterday evening, we were told, when we landed up in the airport, we were told that we need to prepare a PPT. We asked on what exactly. But again, they said some good practices, you can just prepare a PPT, and that's how the PPT has been prepared. And this is on the profile of Karnataka. We have 32 districts as of now. Vijayanagar is a new district that is formed. And we have 4 divisions. That is Bangalore, Mysore, Belagavi, and Kalburgi divisions. We have 11 high priority districts and 2 aspirational districts. Next slide, please. This is about the health infrastructure in Karnataka. We have 19 district hospitals, 19 government medical colleges, and 147 block level hospitals, and 207 community health centers, and 2166 primary health centers, and we have 365 urban health centers, and we have 8,871 sub-centers. Next, please. These are some of the innovations and the best practices which Karnataka has undertaken, out of which I'm going to just give a brief on 3 of the programs. Next slide, please. This is on Ayushman Bharat Arogya Karnataka. Before Ayushman Bharat started, Karnataka already had Arogya Karnataka scheme, wherein we had subsumed various other schemes which were already there in Karnataka, like the Yashaswini scheme, Vajpayee Arogya Shri, RSBY, and Jyoti Sanjeevani. Jyoti Sanjeevani still continues. It is a scheme for the government employees of Karnataka, not just of the health department. It is of all the government departments of Karnataka. The scheme is available for them. The difference between Ayushman Bharat Arogya Karnataka is that Ayushman Bharat covers around 1,349 procedures, but the state of Karnataka, we have combined the Ayushman Bharat Arogya Karnataka, which gives the procedures as 1,650 procedures are covered. Ayushman Bharat, it covers only the BPL patients, but the state of Karnataka, we cover both APL and BPL patients. For the APL patients, the government gives 30% of the cost of the procedure, and the rest is paid by the beneficiary. And this is again 5 lakh rupees is for the BPL patients, and 1,50,000 rupees is for the family of the APL patients. Next slide, please. We have around 3,406 facilities which are providing Ayushman Bharat Arogya Karnataka, which is functioning for the Ayushman Bharat Arogya Karnataka, out of which 525 are the empaneled hospitals, which are empaneled into Suvarna Arogya Suraksha Trust. Until now, we have addressed to around 29,48,600 cases, and which comes to around, the budgeting is around 4,232 crores is spent on the treatment of the public. We have been issuing the Ayushman Bharat Arogya Karnataka smart cards also. But even without the smart cards, we have been accepting the patients because smart cards is not distributed to all. Smart cards are distributed in our healthcare institutions and as well as in the Bangalore one, Karnataka one, various e-governance centers, and even Bapuji Seva Kendra. Next slide, please. This is one more innovation of Karnataka, that is a human milk bank, which is what is called as a comprehensive lactation management center. This is what we thought of starting it during 2021. But during February 2022, we could start one such center at Vanvilas Hospital. And now this hospital has got a very good demand, even from the private sector, that they want the milk from the milk bank. And this has been, we also would want to name it as Amruta Dhare, which is still not been named, but this is what we want to call it as Amruta Dhare. And the second one of that type is was started at Venlock Hospital. This is out of the CSR fund. It is at Lady Goshen Hospital in Dakshina Kannada. And we are trying to, we have also thought of starting it in 4 other revenue divisions of Karnataka, which is of the state fund, but out of the state's fund only. Next slide, please. Why I have put this here? It is that, state of Karnataka has been facing, I think many of the states are also facing, as what was discussed here, the shortage of the HR or the specialists. was what was being done. So state of Karnataka also saw this and wanted to, for the improvement in this or to address the issue of the shortage of the specialists or the doctors, we decided to start the DNB courses. It was during 2016-17. And DNB courses was started. We started DNB courses in 16-17, and this was in the district hospitals. And in the taluka hospitals, we started during 2021. And Dr. NB, that is a super specialization course, also we started in 2021. This was in Wenlock Hospital at Dakshina Kannada. We have got the accreditation for super specialization in urology and pediatric surgery. We also have started diploma courses, and ours is the first state to start diploma courses in the taluka hospitals. DNB diploma courses are started, and the state of Karnataka received Excellence Award for DNB by the Vice President of India. That is on November 2021. This is just a gist of how many hospitals have been accredited by the national board. We have 11 hospitals for DNB, that is district hospitals, and 13 of our district hospitals for the diploma courses, and one hospital, as I said, Wenlock Hospital for Dr. NB. And we have 2 of our taluk hospitals which are also been accredited for DNB, and 19 of our taluk hospitals are accredited for diploma courses. And as of now, we have 249 students who are there into the DNB courses. This year, we are accredited with 296 seats that is approved by NBE. Next slide, please. And I would want to mention here that Karnataka has been helped by the starting of DNB to address the shortage of specialists. That is one. Karnataka has taken a bond from the candidates who come from the outside states, and those who are not in service doctors. We've taken a bond from them that after the successful completion of the course, they're going to work with us for 1 year. And as of now, 18 of such students who have successfully completed the course have applied again. They have come back for the counseling, out of which 4 have already started working in our taluk hospitals. Another 14 are supposed to be given this. After the counseling, they'll be also given the posts. And this is another course that's a paramedical courses. As we were speaking, we were all talking on the discrepancies that has come and the level of, say, economic discrepancies, which has also been a stage wherein various anemia or even the pregnancy or the fertility, everything, it's been backed upon by the economic status of the district or the taluka. This is one course which we started because the students can't be taking up the paramedical courses in a private institute, because every year they need to pay around 85 to 90,000 rupees for the paramedical courses. Looking at this, Karnataka decided to start the paramedical courses in its own district and the taluka hospitals. We have 12 such hospitals which are running the paramedical courses in 7 courses, like diploma in OT technology, diploma in ophthalmic technology, diploma in dialysis technology, diploma in medical laboratory technology, diploma in radio imaging technology, diploma in medical records technology, and we also have health inspector technology. These are the 7 courses we have started. Each course will have 20 students, and we are affiliated to the paramedical board of the medical education. And every year, medical education, the paramedical board will conduct the counseling for the SSLC and the PUC pass students, that is the 10th and 12th pass students. This is a course for 3 years for the 10th pass students and 2 years for the 12th pass students. And the certification is also given by the paramedical board. They also do the internship at our hospitals for 3 months, for which the stipend is also given by the by NHM. 1,200 rupees per month is paid to them. And we have also decided to give them a finishing course, after which they'll be certified by the HSSC and they'll also be recruited. This is what we have planned for these students. And as of now, we have around 6,378 such students who have been taking up the course in our hospitals. Next slide, please. As I've already said, these are the courses and these are the hospitals which are accredited for the paramedical courses. Thank you. And this is our new building, sir, Arogya Sauda. You've not seen, sir. I think you need to come and see, sir. This is where we have all the departments, including SAS, sir. It is in the 7th floor. We have the office for the minister as well as principal secretary, mission director NHM, and the commissioner, and all the officers work here. It's a very nice place. When you please come to Bangalore, all of you can visit our Arogya Sauda. Thank you.
Memento, okay. Ma'am, we would like to present you with a memento. So for that, I request Professor James to please give the memento to ma'am. You can sit here, ma'am, only. Uh, For the chair, we have with us Dr. Jitesh, Executive Director, State Health System Resource Center. No, for the chair, sir, actually it was missed in the starting. Yeah, so now we have the next presentation from the state of Telangana. The presentation would be made by Dr. K. Ramakrishnan, State Program Officer, NHM Planning, Telangana.
Good evening, all. So I quickly go through the PPT. So our major milestones, actually, when our Telangana is a newly formed state 8 years back in 2014 June. So during that time, our MMR was 81. Now, recently brought down it to 56. And institutional delivery is also we have increased from 30% to 51% over a period of 4 years. It was we could able to achieve this increase in institutional deliveries by introducing KCR kit. It's a program it's a software where cash incentive benefits will be given to the pregnant mother from the time of registration to after completion. So this is the strategy for implementing maternal mortality strategy. So this is the there advise pregnant mother for normal delivery and they will practice exercise and all. They will prepare them for they make ready pregnant for normal. care, because also it's a decentralized sensitization effort moved on several sides. Actually, we are in almost more than 90 successive the contract vendor will be providing everything.
So there'll be some discussions on presentations made by the state of Manoj Kumar, Chief Director, Statistics, Ministry of Health and Family Welfare, and
Thank you very much for really helping Government of Kerala and also Health Resource Center led by Jitesh, I think have been actively involved in organizing this and also bringing together the state representative as well as the experts for this workshop. It has been a fascinating one and also plus a learning experience for us as well. I'm sure all of you have enjoyed the complete day-long deliberations on various themes, starting from the morning inaugural session to the end of today, last session. Probably for us, as a data generators rather than the data users, probably we try to understand what is the best way to really derive estimates so that ultimately the purpose is that the estimates we derive is reliable, which really is to the closest to the reality at the field level. But we really don't know. You know much better at the field level what's happening. We have is deriving estimates as possible, as much as possible to the best of our ability to make sure that the quality of the data is the best. We also would like to seek your suggestions because I know when we move from one round to another round of survey, I think any survey is a challenging. We are never close to the reality. You know that every data, any data, whether it is from survey data, whether it is created from the system like HMIS or any data, every data has its own deficiencies. We are sure also, we are also clearly aware of the deficiencies in any survey. So, but the ultimately at the end of the day, our aim is to make sure that these issues or these problems or these deficiencies are as much as possible is reduced the subsequent rounds of the surveys. So that way, if you have any suggestions or any comments on the surveys, please feel free to contact us. We'll be happy to take your suggestions as much as possible, wherever possible, and launch it in a better way in the next round of the survey. As I told in the morning, it should be launched the next year in NFHS 6. So thank you all for joining. It has been a wonderful day for us, and it's quite a bit of learning as well. And all of you who have come from other parts of the other states as well as from other parts of the district, have a nice trip back and look forward to meeting you sometime or sooner in the future. So thank you so much, Francis.
Just a final word. SSRC Kerala is very proud to be associated with the Ministry of Health and Family Welfare, especially this parents institution and IIPS Mumbai. It has been a very fascinating experience over the last few weeks coordinating this workshop on behalf of IIPS and NHSW. We have learned a lot. My team has learned a lot. We have learned some good and some difficult lessons in organizing such big functions. So, and also this association, I think, will be beneficial for the state of Kerala. We have some hidden agendas behind being a partner in this journey over the last 2 weeks. And also, we go all this only because of the immense support which you might have. Everyone here might have noticed that the huge support that I have received from our Prince Secretary and progressors, and also our missionaries who is still with us now as the Princess. The immense support they are giving our team has enabled us as Kerala to do what has been done here today as perfect as we could. Thanks to all those who have come from different parts of Kerala and also from different states, other different states in South India. Hope you have not had any serious issues, though maybe there might be some small issues somewhere, but hope you have not had any serious issues, including accommodation, travel, and the food and other facilities here. Thanks for coming. Thanks on behalf of SSRC Kerala and the Government of Kerala to the IAPS Mumbai and also the Ministry of Health and Family Welfare for their trust in us to organize such a big event. Thank you.
Thank you. I have nothing more to add. Since last 3 weeks I have been interacting with Dr. Jitesh. So I never knew him. So I had an apprehension because I am also a Kerala. So I always have an apprehension and it's slightly difficult to conduct a program from an external agency like Government of India conducting a program in Kerala. A lot of coordination is required. So we used to have a lot of meetings. When I came here, I really found that Dr. Jidesh is working like, yesterday I was telling that, he was putting the backdrop, he was cleaning it. I mean, it's a wonderful experience for me as well. Lot of experience sharing today. To me personally, I learned a lot, especially, from the second half session, that, on STG and PRI's role in health. So personally, we are so happy Government of India extend, complete gratitude to the President Sasi and Government of Kerala for arranging such a wonderful program. This is a motivation for us to conduct more and more program in Kerala again. So thank you for everything, and I would applaud, our girls behind him. There are a lot of girls behind him. I think good support to him. So thank you for accompanying us for the entire day. Thank you so much. I think throughout the day, this anchor, she is not a professional anchor. She is my deputy director, Manvi Agarwal from ISS 2014 batch. So I think she has been, I think, today declared as a professional anchor. I think we will continue her support. So I would request Dr. James to give a.
With this, we came to the end of the event, and just a few lines I would like to add that no one can whistle a symphony. It takes a whole orchestra to play it. The entire team of volunteers working at least for last 2-3 days to make this event happen with such a great success. I, on my personal behalf and on behalf of Government of India, ILPS, Government of Kerala, as an anchor, I would like to thank everybody present here to make this event a successful one. Have a safe journey back home. Your support has made this event a successful one. So thanks a lot. Thank you. Jai Hind.